participants, listeners, ladies and gentlemen. On behalf of the Students' Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2022. My name is Aleksandra Mrozkowiak, and I have a great honor of coordinating the first non-invasive cardiology session.
My name is Olaf Pachciński, and it's also my great pleasure to coordinate this session. I would like to cordially welcome the esteemed jury of our session, the president of the jury, Professor Tomasz Kukulski,
and the members of the jury, Professor Zbigniew Kalarus, who is online.
Dzień dobry. Good day.
Assistant Professor Maciej Wybraniec,
Assistant Professor Paweł Gąsior,
and Dr. Karolina Wrona-Kolasa. Thank you for your presence and the scientific custody of our session. Before I present you the rules that you are obliged to obey, I would like to draw your attention to the scientific patronage granted by Club 30 of Polish Society of Cardiology. Today we are graced by presence of board member of Club 30, Assistant Professor Wojciech Wańcha. Professor, welcome to our session, and I kindly ask you to take the floor.
Thank you for invitation, dear professors, dear young students, dear young scientists. It's a pleasure to be with you today. Me, as the member of the board of the Club 30 of the Polish Cardiac Society, I would like to provide you some information about the club, which maybe you in the future will be interested in. Firstly, the Club 30 is the part of the Polish Cardiac Society. It's a unique young community in the cardiology world. It has been founded in 1994 in the initiative of the Professor Leszek Ceremurzyński as an integration forum for young Polish cardiologists. The main purpose of the club is a platform is to establish networking among young doctors training in the cardiology field. The members of the club shape the face of the Polish cardiology, becoming involved in various clinical, scientific, social, and political activities. Dear students, the main project of the Club 30 are the specialized research fellowship, which support young scientists in the implementation of research programs in the foreign expert centers. The second project of the Club 30 is the Club 30 Scientific Platform, which is the place for initiating multi-center research and writing application for the research grants. There are some strict rules to be the member of the Club 30 of the Polish Cardiac Society. Firstly, the applicant should be the member of the Polish Cardiac Society with the age less than 35 years, and most important point of the membership is the impact factor should be at least 5, which is obtained by the publication of one of the first original articles of the first author. Thank you, and hope to see in the club in the future.
Thank you, Professor.
Thank you very much. And now let's take a look at the rules. Dear participants, before we start the first prelection, let me explain you the principles and the rules of the session. The order of the presentation will be the same as in the abstract book published before the conference. The maximum time of presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time of the presentation, he or she needs to move on to the conclusions and finish the presentation as soon as possible. Don't be afraid, I will let you know, gently, that the time has just passed. Please remember that all the presentations and the discussion must be run in English.
Esteemed jury, we ask you to assess 4 aspects of each prelection. First one is scientific value, second one, the way of presenting, the third, discussion, and the last one, own contribution of the participant. When the session ends, I will kindly ask you to give the cards back to us. I would like also to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Of course, other members of the same clinic can assess the presentation, and the assessment will be verified.
These are all rules and regulations that we need to observe. But if something is unclear, I would be glad to answer any questions you might have. If not, I would like to welcome on stage Szymon Staneta with a presentation Fragmented QRS Incidence in Standard Electrocardiogram in Patients with Systemic Lupus Erythematosus.
The floor is yours.
Here.
Ladies and gentlemen, good morning. My name is Szymon Staneta from Medical University of Warsaw, and I feel privileged to show you mine and my colleagues' work entitled Fragmented QRS Incidence in Standard ECG in Patients with Systemic Lupus Erythematosus. So, first things first, let us lay the groundwork. SLE is a connective tissue disease, or CTD for short, and as with most other CTDs, it is a chronic inflammatory disease of unknown etiology, though we know that it is autoimmune in nature. The systemic part signifies that it can involve connective tissue in every and any organ of the body, and that, of course, includes the heart. And heart involvement can lead to arrhythmias and conduction disturbances, which in turn lead to increased mortality, which is obviously a huge point of concern. That leads us to the ECG, which is an easy yet important test that can detect heart problems. We set out to assess whether or not FQRS can be an important parameter in SLE patients. What is FQRS? It stands for Fragmented QRS, and it is a fairly new, easily evaluated parameter that is defined as either an additional R wave or a notch in the nadir of the R wave or the S wave in two contiguous leads corresponding to a coronary artery territory. And you can see examples of FQRS on the screen right now. The presence of fragmented QRS has been associated with alternation of myocardial activation, either due to scarring and or fibrosis. And as such, fragmented QRS is thought to be a potential marker of cardiovascular risk. So what we did was we analyzed ECGs of SLE patients manually under expert supervision. And among other evaluations, we took a look at the incidence of FQRS according to DAS criteria, which I just talked about. We also estimated the severity of the disease using SLEEK ACRDI score, which is a damage index developed to quantify the amount of damage that has occurred since the onset of lupus. A word about the population of the study. As you can see up on the screen, a total of 77 patients previously diagnosed with SLE have been entered into the study, and a control group of 40 healthy people has been formed. In both groups, the majority were women, and they were in the same age group, approximately 45 years of age, with median disease duration in the SLE group being 9 years. On to the results. Let me start with some ancillary information. Mean value of LVF was similar in both groups. Hypertension incidence, almost 50% in SLE, but that is to be expected. It is in line with information found in literature. And SLE patients in our study also presented prolonged QTC interval. And when it comes to the actual aim of the study, we found FQRS in almost 40% of SLE patients and in just 3 controls. FQRS most commonly had to do with R wave, with notch tests only making up about 8 of the cases. Interestingly, in some patients, different FQRS can coexist. We found that in SLE, FQRS were similarly frequent, irrespective of the duration of the disease or the severity of the disease. So, to sum it all up, we found that patients with SLE present a multiple times higher incidence of FQRS than healthy subjects. It is not out of the question that FQRS may be considered an additional marker of heart involvement in SLE. There are hopes that it could predict future cardiac complications earlier than the methods that we currently use. However, in our study, no relationship between FQRS incidence and longer duration or more advanced disease was observed. I think that a possible a follow-up study could include correlating FQRS incidence with MRI results, or perhaps even a prospective study that could tell us if FQRS is associated with worse cardiac outcomes in the future. Thank you for your attention, and that is all from me today, and I await your questions.
Does anyone of the esteemed jury has any question?
I congratulate you on your work. I'd like to ask you a question about the number of true right bundle branch block diagnoses in your group, because I think it's quite interesting information, and that would add to the amount of patients who actually had some fragmented QRS but did not have RBBB, because you said that there's the majority of them had notched R-wave. But how about it, like the fulfilled criteria for RBBB diagnosis?
Yes, I understand your question. It's a very good question, and I should probably add at the beginning that for bundle branch blocks, the criteria for FQRS is slightly different. We'll need additional R-wave, so more than 2, in order to say that there is an FQRS in RBB. As far as our patients go, there were no cases of bundle branch blocks at all, so this was not a problem.
Okay, thank you. And I have another question regarding the control population. So how did you select the control group? Because we have 77 patients in the studied group and only 40 in the control group. And how were they selected?
Yes, I believe the main point of the selection was to have a group that was consisted mostly of women and they were in the same age group. I'm not aware of any additional criteria that were employed.
Okay, and there was any differences in the baseline parameters between those groups? The age was similar, because the rate of women was also similar.
Yes, the rate
right?
of women were similar and the age was pretty much the same. Well, the same age group, as close as you can get.
Okay, thank you.
Congratulations for this work. Fragmented QRS seems to be a marker of myocardial fibrosis, the potential marker. You have found in your work that also in the control group this phenomenon was present. What about the other markers of fibrosis that could be the real reference marker, reference method? I think, do you think that the assessment of the fibrosis using MRI or biopsy potentially should be done in order to establish whether the fragmented QRS is a viable marker of heart involvement?
I think this is exactly what should be the next step, because what we did was we compared FQRS results with not just the duration and the severity of the disease, but also echocardiography readings. But I think that in our patient population, the disease was too mild to really see any changes, because echocardiography is just a crude representation of what the heart looks like. So an MRI could definitely give us more information about if there really is fibrosis.
You showed that the ejection fraction in the lupus erythematosus group was normal.
Exactly, no changes in the echocardiography so far.
Did you look at any other markers of subclinical disease?
You mean in echocardiography? Yeah. Yes, we analyzed all the more important parameters, should I say. Perhaps we didn't go into some extreme detail, but for the most part, there were really no abnormalities. Maybe, yeah, pretty much. That's pretty much it.
Okay, thank you.
Thank you very much for all the questions. Thank you very much for your presentation.
Thank you.
Thank you for the discussion, and in the meanwhile, I'd like to remind you, dear participants, that the question can be asked also by you, so feel free to take the floor. And now I'd like to invite to the stage Filip Baranowski to present the work entitled Analysis of Differences analysis of differences in clinical parameters, comorbidities, and the incidence of selected defects among patients with valvular heart disease with regard to age.
Thank you. Good morning. We found that there is limited research available on the topic of differences caused by age and clinical parameters in conjunction with select comorbidities in patients with valvular heart disease. Thus, we wanted to assess those parameters in our large study group. In our study group, we analyzed 680 patients that were hospitalized in the John Paul II Hospital in Krakow in the first half of the 2017. And we found out that the mean age of our study group was 69.2. The youngest patient was 21 and the oldest was 97. Mean age of male patient was significantly lower as compared to female, as you can see here on the graph. And our findings were that in the group of patients with aortic stenosis, the mean age was significantly higher than in the rest of the analyzed database, with p-value 0.005. And the same applied to patients with tricuspid regurgitation. Patients that had undergone the following procedure as PCI or CABG were found to have had significantly higher mean age than the rest of our study group. And the mean age of patients with ICD device was lower, but the difference was not statistically significant with p-value 0.066. In terms of CRT device, there was no significant difference in the mean age of patients with or without CRT device. Patients with pacemakers were significantly older with p-value 0.001. And the difference was not also statistically significant when it comes to patients with heart failure exacerbation. As it comes to medication, we observed statistically significant differences in the mean age of groups taking dabigatran, apixaban, ACE inhibitors, and statins in comparison with the rest of our study population. And the patients that smoke actively had lower mean age than the patients that denied smoking at admission. And finally, the mean age of patients that have had previous high history of myocardial infarction was significantly higher than those who have not had a heart attack, with p-value 0.004. Patients that demonstrated symptoms of heart failure were significantly older than patients without those symptoms. And this work contributes to existing knowledge of the differences caused by age in older patients with valvular heart disease in comparison to younger patients. The second major finding was that there were no significant difference in the incidence of heart failures, PCE procedures, CRT, or ICD implantation related to the age. And as you saw, we found significant differences between younger and older patients, but more studies, including comparative studies with the general population, are needed to elucidate fully the differences that age makes in patients with valvular heart disease. Thank you very much.
Thank you for the presentation, and now I'd like to start the discussion.
Thank you. I'd like to ask you quite an important question about the inclusion criteria, because you mentioned that that the study comprised patients with valvular heart disease, but were these patients with significant valvular heart disease? Because it's important to point out whether it was just a general diagnosis of any valvular heart disease, even mild or moderate, or only the severe cases. This is quite important because that would explain maybe the amount of patients you qualified to your study, because it's quite a high number within a short period of time. So please explain.
Okay, so we would like to assess all the patients with valvular heart disease, diagnosed previous, diagnosed on admission, and diagnosed after admission.
So that means also mild valvular heart disease?
Yes, exactly.
Okay, thank you.
No questions from the audience? Not yet. The group you have presented, it's a quite unhomogeneous degree of the heart valve disease has been already mentioned. And another thing which is important to clarify in this work is the type of the valve disease, because what is really related to the age is a type of the valve disease. So I think that it would be interesting to look at the differences in aortic stenosis, which is, as we know, actually the valve strictly related to the aging of patients. And I think that you will probably find completely different results in the patient with the primary mitral regurgitation, which is actually the valve related to the younger population. So I think this is important to make the distinction not only between patients with the certain degrees of mitral valve disease, but also type of the mitral valve disease. So my question is whether you looked at differences, for example, in patients with aortic stenosis and in patients with organic mitral disease, mitral regurgitation.
This abstract is part of our bigger publication, and in this publication we would like to focus on certain type of valvular heart diseases.
Okay, and the last question, what was the your input, your impact on this work?
We were collecting the part of database, and we were making phone call to patients after 5 years.
Thank you.
Any other questions? Okay. Thank you so much for the discussion and for your work.
Thank you very much. And now please welcome Kamil Górny with a presentation Clinical Characteristics of Arterial Flutter and its Response to Pharmacological Cardioversion with Amiodarone.
Good morning, ladies and gentlemen. My name is Przemysław Szyszka, and I'd like today to present you results of our study about clinical characteristics of atrial flutter and its response to pharmacological cardioversion with amiodarone. First things first, I'd like to quickly remind what exactly is atrial flutter. It's quite common supraventricular tachyarrhythmia with atrial rate between 250 and 350 beats per minute. It can be triggered by many conditions like myocardial infarction, hypertension, or hyperthyroidism. It can be treated with electrical cardioversion, ablation, but it can be considered to treat with antiarrhythmic drugs like amiodarone. We can simply classify atrial flutter into typical and atypical one. And the main difference is that the typical one is dependent from the cavo-tricuspid isthmus and the atypical one isn't. The aim of our study was to evaluate the clinical characteristics and management of patients with atrial flutter, and then the comparison of the atrial flutter group of atrial fibrillation. They were subject to pharmacological cardioversion with amiodarone. Our retrospective analyses were 222 patients. They were consulted in emergency department of Upper Silesian Medical Center between 2015 and 2018. Among these patients, we've chose 59 patients with atrial flutter, and then we compared them to the control group of 60 patients with atrial fibrillation. These patients matched in terms of age and sex. We've included to our study patients with diagnosed atrial flutter based on 2 ECG criteria. The first was regular atrial activity between 250 to 350, and the characteristic sawtooth pattern of inverted flutter waves in lead second, third, and AVF. The primary endpoint of our study was conversion to the sinus rhythm. We've excluded from our study patients under age of 18 and any case of unknown conversion to the sinus rhythm. In case of our population, most of them were men, almost 2/3. Most of the patients were aged over 65 years, and the smallest group were women aged under 65. Well, now let's move on to the results. Our population was characterized by median CHA2DS2-VASc score of 3 points, median duration of episode of 72 hours. We've taken into consideration hypertension and diabetes type 2 as the comorbidities. 25% of the patients had both hypertension and diabetes, 42% had only hypertension, and 3% had only diabetes type 2. In echocardiography, we looked at left ventricle ejection fraction and left atrium linear dimension. These patients, 38% of these patients had lower LVEF than 50%, and 77% had LAD thicker than 40 millimeters. And in case of kidney function, 30% of the patients had eGFR lower than 60 milliliters per minute. Regarding the conversion method, the most popular one was pharmacological cardioversion with 36% of share. A little less popular was electrical cardioversion. Both ablation ad hoc and delayed ablation had 40%, and almost 10% of the patients spontaneously converted to the sinus rhythm. In this chart, you can clearly see that the electrical cardioversion was almost 100% successful, and pharmacological cardioversion had 2 times less successful rate. Now let's move on to comparison of our atrial fibrillation and atrial flutter groups. Both of these groups were in a similar age, with the median with 68 years in atrial flutter and 69 in atrial fibrillation. Most were men. Almost three-quarters of the patients had hypertension in both of these groups. Much less common comorbidity was type 2 diabetes, and the most of the patients with heart rate over 150 beats per minute were in the atrial fibrillation group. Regarding to ejection fraction and eGFR, atrial flutter group had lower ejection fraction and eGFR than the atrial fibrillation group. The use of anticoagulants were comparable, and the atrial flutter group had higher troponin levels. Now you can more clearly see how many more patients from the atrial flutter group had LVEF and eGFR lower in comparison to atrial fibrillation. Regarding efficacy of pharmacological cardioversion with amiodarone, it's clear that atrial fibrillation was more prone to conversion to the sinus rhythm than the atrial flutter group. To sum everything up, atrial fibrillation is associated with many comorbidities and lower heart and kidney function. And these patients have high prevalence of diseases like myocardial infarction or heart failure. Therefore, atrial flutter should be terminated as fast as possible following diagnosis. As the study shown, the best way of converting is electrical cardioversion with almost 100% rate. And pharmacological cardioversion is much less effective, so it shouldn't be considered as the first choice of conversion to the sinus rhythm. If the electrophysiology lab is available, therefore ablation should be considered because it's the only causal treatment in atrial fibrillation. Thank you.
Thank you very much for your work, and now let's start the discussion.
I give Karol Zbigniew two short questions. Please tell us what was the percent of patients with atypical atrial flutter in the study group? This is my first question. And second, the ejection fraction was evaluated during sinus rhythm or during arrhythmia?
The typical atrial flutter is much more common. Now, I don't have exact numbers, but it will be in our article in the future. And can you repeat the second part of the question?
Evaluation of ejection fraction was performed during sinus rhythm or during arrhythmia in both groups?
It was evaluated in the day of admission to the emergency department in a hospital during the arrhythmia episode.
Okay, thank you.
Thank you.
Any other questions?
So what was your personal involvement in the study? What did you actually do as a student?
Every member of our group had same amount of patients to gather information to our database and then to make statistics. And every one of us had almost same contribution to making the presentation.
Thank you.
Just comment related to this work. Since you looked at baseline clinical characteristic of the patients, did you also look at the predictors of effectiveness of cardioversion? Which of the clinical parameters are a good predictor of effectiveness of pharmacological cardioversion?
We've looked at the conversion of the sinus rhythm to the sinus rhythm during the stay in the hospital, and then if the patients came to this hospital again, we've checked if it was because of the same arrhythmia. So if there wasn't any patient with this type of arrhythmia, it's considered as a successful.
Do you have also data about the duration of arrhythmia before cardioversion?
Yes, the median was 72 hours of episode. Mostly it was lower.
Okay, thank you.
Thank you very much. Thank you for the presentation.
Thank you.
The next work, entitled Discrete Subclinical Abnormalities in Patients with Preserved Left Ventricular Ejection Fraction, is presented by Albert Juszczyk. I will give the floor.
We have a technical problem.
Sorry, give us 2 minutes, okay? We need to fix it.
Okay, so good morning. My name is Albert Juszczyk. I'm from Jagiellonian University, and I will be presenting the results of our research titled Discrete Subclinical Abnormalities in Patients with Preserved Left Ventricular Ejection Fraction. Endothelial dysfunction accompanies cardiovascular risk factors and is a well-known predecessor of atherosclerosis. Endothelial dysfunction appears to associate with heart failure with preserved ejection fraction by a variety of metabolic and hemodynamic mechanisms. Also, renal insufficiency predisposes to both endothelial dysfunction and heart failure with preserved ejection fraction. However, there is a paucity of data on possible associations between endothelial, metabolic, renal, and hemodynamic parameters in patients who do not meet the current definite criteria of diastolic dysfunction. Our aim was to estimate possible associations between these parameters in such patients undergoing routine coronary diagnostics. It is a cross-sectional analysis of 27 hospitalized patients with exertional dyspnea and probable but not definite diastolic dysfunction. Patients had coronary angiography performed to exclude significant coronary artery disease, and our study lasted from December 2020 till February 2022. Exclusion criteria were significant coronary artery disease, atrial fibrillation, estimated glomerular filtration rate less than 45 milliliters per minute, ejection fraction less than 50%, more than mild valvular heart disease, and the definite diastolic dysfunction. Inclusion of each patient took approximately 3 hours, including medical record screening, interview and physical examination, measurement of endothelial function by endopath, and transthoracic echocardiography examination. Each patient had additional blood tests performed. These were glucose, insulin, glycated hemoglobin, creatinine, and T-proBNP, and lipid profile. We gained a preliminary echocardiography experience so that we were able to perform an echocardiography examination for the purposes of this study under the supervision of one of our tutors. Endopath is a non-invasive procedure for assessing the endothelial function. It measures a pulsatile volume change at the fingertips before and after the 5-minute occlusion of the brachial artery. Endopath provides a reactive hyperemia index, which is the ratio between the post-occlusion and the pre-occlusion pulsatile volume change. The higher the reactive hyperemia index, the better the endothelial function. The whole procedure takes roughly 15 minutes. As you can see here, our patients were on average 63 years old, 59% of them were female, most of them had hypertension or dyslipidemia, 37% of them had diabetes, mean BMI was 31.5, mean ejection fraction was 62%, mean E to E prime ratio ranged from 3.9 to 12.5, and only 11% of our patients had tricuspid regurgitation velocity greater than 2.8 meters per second. These are blood test results of our patients. Median NT-proBNP was only slightly elevated, and our patients were generally metabolically well controlled and had relatively good renal function. When it comes to the results, average mitral annular systolic velocity, S prime, correlated negatively with logarithm of HOMA-IR. So the greater the degree of the insulin resistance, the worse the systolic function of the left ventricle. It was a medium correlation. S prime correlated negatively with index left atrium area. So the bigger the left atrium, the worse the systolic function of the left ventricle. It was also a medium correlation. S prime correlated positively with estimated glomerular filtration rate. So the better the renal function, the better the systolic function of the left ventricle. It was also a medium correlation. And S prime correlated positively with mean early mitral annular diastolic velocity. So the better the diastolic function of the left ventricle, the better the systolic function. It was also a medium correlation. Ejection fraction, however, was unrelated to any of the parameters. Reactive hyperemia index correlated positively with estimated glomerular filtration rate. So the better the renal function, the better the endothelial function. It was also a medium correlation. In conclusion, discrete subclinical impairment of both systolic and diastolic left ventricular functions develops in parallel with insulin resistance and renal dysfunction in patients prior to the onset of definite diastolic dysfunction. Secondly, renal and endothelial dysfunction appear interrelated. Thirdly, indices of subtle diastolic and systolic impairment correlate with each other. Our preliminary findings may suggest the importance of aggressive measures to prevent both chronic kidney disease and heart failure. Thank you for your attention, and I'm looking forward to your questions.
Thank you, dear participant, and we can start the discussion. Professor.
Thank you for your presentation. Also, the number of patients is relatively low. So the concept of this study is interesting. My question is related to the practical, possible practical feedback from this, from your work. To measure the subclinical abnormalities before the beginning of diastolic function is a challenge. Yeah. Why do you think that we should look at the subtle changes before the diastolic? Because we still have a problem with the proper measurement of a diastolic dysfunction in patients with normal ejection fraction.
And so we based this probable diastolic dysfunction on the Heart Failure Association of the European Society of Cardiology 2019 consensus about diagnostic algorithm of heart failure with preserved ejection fraction. So there is in the second step there is a score. Yes. So there is a score, and when here you have major and minor criteria. And when the patient gets 5 points or more, there is a definite diastolic dysfunction, and 2 to 4 points, we accepted that this is a probable diastolic dysfunction because these tests are rarely routinely performed. So these patients, in practice, we do not actively look for these patients, but these are the subjects that have some exertional dyspnea or some of unknown origin, but no significant coronary artery disease, and we do not have the definite criteria met to diagnose them with heart failure with preserved ejection fraction. And I know it is difficult to diagnose both heart failure with preserved ejection fraction and diastolic dysfunction, so it is an area for the further research probably.
Okay, but the results you have showed in your patients of the characteristic, you showed that the patients did not match the criteria of diastolic dysfunction.
Yes.
All these patients, these are patients without recognized diastolic dysfunction. So what would you recommend to measure to find out the early stages of abnormal endothelial response, for example?
So for measurement of the endothelial response, the measurement is endopath, so the reactive hyperemia index. However, it is a quite expensive procedure because the finger cups that we use costs roughly 600 zlotys, and they are single use. So practically it is really difficult to put that into like everyday practice, but it may be a good solution for like more complicated patients.
your work is very complex, and this is a very difficult field because, as Professor Górski said, diastolic dysfunction is a very difficult topic also for cardiologists. But what I would like to stress that comorbidities are more prevalent in HFpEF than HFrEF. So this heart failure with preserved ejection fraction, the focus is not only on treatment of the heart failure itself, but on handling the comorbidities. So I think the most common one will be arterial hypertension, and thus I think that apart from like diagnosing the preclinical changes in morphology and function of the left ventricle, just handling hypertension is the key pre-HFpEF task we should address. So I think like handling comorbidities should be first, and then if we actually see some diastolic dysfunction, then of course we can diagnose HFpEF. But I mean, first is like comorbidities. This is what actually what these are the predecessors of HFpEF. Yes. Yeah. Thank you.
Thank you.
What are your personal input in this work?
So for the time that I stated, we every week, excluding summer vacations, we went to the clinic and we searched for the patients. I performed roughly 1/3 of the echocardiography examinations under the supervision, and probably most of the endopath assessments.
Okay, thank you.
Thank you.
Thank you for your work and for the discussion.
Thank you very much.
Thank you very much. And now please welcome Krzysztof Irlik with his presentation, Influence on Different Therapeutic Interventions on Thrombus Resolution in the Left Atrial Appendage.
Okay, good morning, ladies and gentlemen, dear committee. My name is Krzysztof Irlik, and I represent First Department of Cardiology in Zabrze. And the subject of my presentation is the influence of different therapeutic interventions on thrombus resolution in the left atrial appendage. And to start off, this subject is relevant because thrombi forming in the left atrial appendage are a common cause of stroke. And we have some tools and landmark clinical trials that shows us how should we prevent this thrombi from forming in the left atrial appendage. However, if we do have a patient with atrial fibrillation and we find thrombus in his appendage, then there is very weak evidence regarding efficacy of different therapeutic interventions that we could employ to treat this patient. There are some retrospective studies, there is one exploratory prospective study, and there are no randomized clinical trials. And this is not just because nobody wants to do research in that area. This is because it's difficult to do studies like that. And it's difficult because in just few % of patients that have atrial fibrillation and are and undergo transesophageal echocardiography, thrombus in the left atrial appendage is found. So trials that want to do research like that are prone to have difficulties with patient enrollment. Now, the aim of this study was to explore what therapeutic strategies are used to treat patients with thrombus in the left atrial appendage, and whether any of these clinical practices is more efficacious in thrombus resolution than other strategies. And in order to do that, we ran a retrospective observational study. We had 31 patients with either atrial fibrillation or atrial flutter with thrombus detected in the transesophageal echocardiography. And 22 of these patients were followed up with another transesophageal echocardiography. So the first results I would like to point out is that there were 3 main strategies that were used by clinicians. The first one was to switch currently used vitamin K antagonist to a novel oral anticoagulant. The second strategy was to change currently used NOAC to another type of NOAC. The third was to administer low molecular weight heparin, and additionally, just few patients that had high bleeding risk had left atrial appendage closure despite having thrombus in the appendage. Now, in this alluvial diagram, you can see what medications patients took initially and what medication they were given after they were diagnosed with thrombus in the left atrial appendage. And I roughly summarized this diagram just a moment ago. But again, I think there is one interesting thing, is that actually patients taking NOAC and vitamin K antagonist had similar, similarly treated in the end. So they either mostly took heparin, or they took another type of NOAC, or they started NOAC if they took vitamin K antagonist. However, patients with vitamin K antagonist rarely remained on this treatment with vitamin K antagonist. So we can stratify these patients into 2 groups. One group which achieved thrombus resolution at follow-up, and the other which still had thrombus at follow-up. And we can see here that patients that achieved thrombus resolution were most commonly treated with NOACs, and the other group which still had thrombus were most commonly treated by heparin. However, differences between these groups in terms of interventions that were used was statistically non-significant. And to conclude, there is no systematic way of treating patients with thrombus in the left atrial appendage, and numerous methods are used to do so. And most of the patients that achieved thrombus resolution were treated with NOACs. However, no particular strategy was found to be significantly better than others. Now, finally, I would like to highlight some limitations of this study. So this sample size was small. And we are very unlikely to have any significant findings. Approximately 1/3 of patients were lost to follow-up, as they did not have another transesophageal echocardiography, and we did not have follow-up of clinical outcomes such as death, stroke, or bleeding. And thank you very much for your attention. If you have any questions, I would be pleased to answer them.
I have a very provocative question, because you mentioned that you had 22, yes, or 30 patients with thrombus diagnosed on TE on anticoagulation. My question, yes, they were already
mostly over. I think about 90% were anticoagulated.
Do we need to treat this thrombus, and why?
So it's a very interesting question, because actually, if you try to find any studies that just take patients with thrombus in the left atrial appendage, there are no such studies that show that these patients have increased risks of stroke. I did not find any. Maybe you could find some randomized trials that have subgroup analysis, where especially in studies where before cardioversion, where a lot of patients had TEE, they were diagnosed with a thrombus in the left atrial appendage, and maybe then you can see that these patients had thrombus, and maybe they had increased risk of stroke, but I did not find such detailed analysis anywhere.
Thank you. That's a very good answer to my question, because actually we treat it because we want to perform some procedure, for instance, electrical cardioversion or pharmacological cardioversion, rarely, of course, or PVI, so pulmonary vein isolations or ablation of AF, then we try to combat this thrombus in order to have the possibility to perform these procedures. But if we have a patient on chronic anticoagulation and we detect thrombus in left atrial appendage, and we do not plan, for instance, the patient has permanent AF, so we don't want to cardiovert it, we think it's pointless, then we actually don't have any evidence that this thrombus on chronic anticoagulation increases the risk of stroke, although maybe in future such data will appear. So thank you.
Yeah, so good point. I think there is substantial pretest probability that this thrombus may increase risk. Like that's why we anticoagulate patients. And yeah, in our study, also patients were generally admitted for cardioversion, ablation, or left atrial appendage closure, and they could not have this intervention mostly, apart from few patients with left atrial appendage closure, if they were diagnosed with this thrombus in the appendage.
One question, one comment. Who was an expert in terms of assessment of the thrombus? So you personally draw the conclusion that this is a thrombus, or this is already, let's say, increased, let's say, intensity of echo. So there's a, okay, first the question.
Okay, so if it was possible, and it was generally possible, we just look at the conclusions of the operator, if there was a thrombus and there was not thrombus, and also if operator had some doubts, he usually used contrast. However, we also collected some other data on this transesophageal echocardiography, if it was recorded, like the surface of the thrombus and some other aspects. However, it was not presented here. But we did not include a spontaneous echo contrast as a thrombus in any way.
Okay, and the comment would be that I really encourage you to continue this work. The number is relatively low. We have hundreds of patients like that, so probably for the next presentation next year, you should expand your work. And regarding the lack of evidence between the presence of thrombus and possible risk of stroke, we have procedure that we can perform with, let's say, relative contraindication in terms of the presence of atrial appendage. You know such a procedure that you can perform even if you have a thrombus in the left atrium?
I mean, so I think you mean left atrial appendage closure with neuroprotection, and it was performed in, I think, 3 patients in our study group. However, the rest that was indicated for left atrial appendage closure was not performed. I mean, this procedure was not performed.
And there's also the strong evidence that you can perform balloon mitral valvulotomy even if you have thrombus in left atrial appendage. So I agree with the coach.
And maybe last question from me, because this study actually assessed a different therapeutic intervention on thrombus resolution, right?
Yeah.
So why did you actually include the procedures of left atrial appendage closure? Because doing this with the presence of thrombus in the LAA, we do not actually resolve the thrombus, we just entrap it within a left atrial appendage, right? So
right. We didn't, I mean, we looked at these patients that had left atrial appendage closure. We did not like to just exclude them. because we feel like it. And if you see this, this graph where we show patients with resolved thrombus and without resolved thrombus, then we did not include these patients in here.
Okay, thank you.
Thank you very much. What is your own contribution in this work?
What
is your own contribution in this work?
Oh, so our contribution to this work is that we collect the clinical data on these patients, and also some echocardiographic data. And if this echocardiographic data was lacking, we measured it ourselves under supervision of our tutor.
Thank you very much for all the questions, and thank you for your work.
Thank you.
The next presentation will be presented by Bartosz Gruchlik, who is asked to come to the floor. And the title of the work is CMR of the Heart, the Diagnosis and Activation of the Myocardium in Patients with Acute Cardiac Inflammation. Oh, excuse me. Okay, Martyna Nowak, sorry.
Thank you. Good morning, ladies and gentlemen. My name is Martyna Nowak. I'm a fourth-year medical student at Medical University of Silesia. And today, on behalf of the whole team, I have the privilege of presenting to you our research regarding cardiac magnetic resonance imaging, the diagnostics and degree of myocardial damage in patients with acute myocarditis. The diagnostics of acute myocarditis is complex. Hence, the clinical criteria and laboratory tests are sometimes insufficient to make an unequivocal diagnosis. Therefore, it's becoming increasingly more frequent to use supplementary diagnostic techniques. Now, myocardial biopsy is still considered to be the reference standard for definitive diagnosis. However, it is not routinely used due to its invasive nature and associated risks. For that reason, the significance of CMR as a way to make the right diagnosis is growing. Now, CMR is the most important imaging modality in for evaluation of acute myocarditis, with typical findings of focal and diffuse edema and myocardial damage, including late gadolinium enhancement. As you can see on the diagram, it is quite crucial in the process of diagnosis and recommended in most cases. The aim of our study was to determine how often CMR is actually used in the diagnosis of acute myocarditis and possible associations between CMR findings and the degree of myocardial damage determined by myocardial necrosis markers. How we were doing that. So we analyzed 83 patients hospitalized due to acute myocarditis between years 2015 and 2022 in the first department of cardiology in Upper Silesian Medical Center in Katowice. We compared the lab test results such as troponin T, CKMB and CRP levels, as well as transthoracic echocardiogram results in relation to some CMR parameters. In this case, it was left ventricular ejection fraction, the presence of myocardial edema, and number of segments with LGE. Now, regarding the characteristics of the study group, out of 83 patients, 36 had CMR done, which makes 43%. In this group, patients were mostly male, with average age 38 to 40 years old, and the severity of heart failure mainly at the NYHA class 1 and 2. Now I would like to present to you the actual method of quantifying LGE in short axis CMR using Cardiac VX, a software program that enables the analysis of key cardiac parameters. So in order for the program to quantify the actual exact number of occupied segments, first we have to quantify LGE in each segment individually. So the first step is delineation of endocardial contours, which you can see in red here, and epicardial contours, which you can see in green color on this picture, which will mark the myocardium borders. The next step is marking the intersection between right and left ventricle. That's the X on the picture. That way we get LGE. The pink enhancement that you can see is the LGE area. In this case, it's the interseptal and subendocardial area. Laboratory test results showed some differences among patients with CMR done and without CMR. In the group of patients with CMR done tended to have intercurrent hypertension, slower heart rate, as well as lower levels of glucose, CKMB, and CRP. The levels of troponin T were also slightly lower, although not statistically significant. Echocardiography results showed that patients with CMR done had left ventricular ejection fraction slightly lower than the other group, with the volume of left ventricle being slightly higher, as well as the left atrial area. The right atrial area, the differences between right atrial areas were not statistically significant, and by analyzing these variables, we can conclude that the group of patients with CMR done had less distinctive symptoms, both clinical and laboratory. And now moving on to the CMR results. 50% of patients had LVEF over or 55%. Myocardial edema was detected in 26 patients, which makes 72% of cases. And late gadolinium enhancement was present in all cases. The number of occupied segments was significant in each case, and it ranged from 6 to 10 in 11 patients, which makes 30%, to 11 to 16 in 25 patients, which makes 70%. And as you can see on this graph, there were no significant correlations between LVF, presence of myocardial edema, a number of occupied segments, and levels of TNT, CKMB, and CRP. And to sum up, although CMR is significant in the diagnostic process of acute myocarditis, it is not essential, and therefore still not fully utilized. Current use applies to patients with less pronounced symptoms, suggesting the diagnosis. In patients with mild clinical causes, the diagnostic markers of myocardial damage are not related to the severity of changes presented in CMR. Thank you for your attention.
Thank you for the work, and I start the discussion. Is there anyone who wants to ask the question?
Maybe because I'm from this department, I'll just comment that the decision to perform CMR and not to perform frequently is based on the availability of the procedure, because sometimes we cannot perform it because of the queue and because of the availability. So I think all patients with myocarditis should undergo CMR in order to establish or to exclude the active inflammatory process. So I would like to congratulate you on your work.
Thank you.
As I understood, you look at 76 patients, yeah, in total?
86.
Yeah, it means that there were two groups, the CMR plus, CMR positive. It means that these are the patients with confirmed myocarditis, 36, yeah?
All
and
of the
47 with a negative results.
Yeah.
Also, all of them.
The 43 patients didn't have CMR performed.
So 47 patients without confirmed myocarditis.
No, all of the patients had confirmed myocarditis. Just 47
what
in
does
47.
It mean, CMR minus?
That the CMR was not performed.
Okay. Okay. Atrial fibrillation or other forms of arrhythmia, was it really the problem in the assessment of analysis of CMR data?
No,
because we often observe ventricular ectopy in most of the cases or atrial fibrillation. So how many of these patients were excluded from the analysis, or this was not the case?
No, we didn't exclude any patients due to that that condition.
So did you actually look at any follow-up of these patients?
No,
Okay.
we didn't do any follow-up with these patients.
Okay. And what was your personal input in this paper?
So we chose we found the patients with acute myocarditis in the hospital database. We analyzed the records. We created our own database, and we found the patients with CMR done. And then we quantified ourselves the LGE, the late gadolinium enhancement in the cardiac physics.
Okay, so the patients for the study were actually selected based on the final diagnosis on the discharge paper, right?
Yes.
And they were retrospectively analyzed.
Yes.
Okay, thank you.
Are there any other questions? No. Okay, thank you for this disputable topic.
Thank you so much.
Okay, and now I would like to invite Michalina Perzanowska with her presentation, Diagnosis of White QRS Complex Tachycardia based on 3-channel Holter recordings.
Welcome everyone, my name is Michalina Perzanowska, and today I would like to present our research, which is titled Diagnosis of White QRS Complex Tachycardia based on 3-channel Holter recordings. As for some background, as some of you may know, ventricular tachycardia up to this day remains a diagnostic challenge, especially since it's very difficult to differentiate it with supraventricular tachycardia. But as of now, we have certain algorithms like VT score, Brugada or Veretsky, that help us diagnose ventricular tachycardia. But all of those have one downside. They are all compatible for 12 lead ECG. And unfortunately, there are none algorithms that would allow us the diagnosis for 3-channel Holters. And the Holter is a basic diagnostic tool for this kind of disturbances. So this is why my colleagues and I decided to assess whether it is possible to diagnose ventricular tachycardia based on 3-channel Holter recordings using chosen indicators. And so we took 154 Holter recordings, out of which 144 were VT recordings and 10 were SVT recordings. And we decided to assess the following indicators for all 3 channels: duration of QRS complex, VT cycle, atrioventricular dissociation, and positive or negative concordance. And for each channel separately, type R or QS of QRS, duration of RS, notch in QRS complex, Q greater than R, and the duration of QR. And here are the obtained results. As you can see, we decided to point out the indicators with occurrence higher than 25%. And we also measured the same for our SVT group. And we decided to put it on graph for comparison. As you can see, based on the graph, there is nothing significant. There are no significant differences between the groups. So we decided that maybe we would be able to create some kind of an algorithm to see if there are differences between those two groups. And so, based on the obtained results, we chose indicators with occurrence over 25% and created this score. Atrioventricular dissociation was assigned 2 points, and then the rest of the indicators were assigned 1 point. Maximum score is 8 points. And so, based on that algorithm, we calculated that the average score for VT was 3.23 and for SVT was 2.1, and median was 3 for VT and for SVT 1. And as you can see in the table on your right, most of VT recordings were actually scored over higher than 3 points. And so, in conclusion, based on our research, the only indicator that can confirm the ventricular origin of arrhythmia is atrioventricular dissociation, but more indicators are present, the higher probability of ventricular origin, and also further analysis of SVTs registered by ECG Holter recordings is required, as the comparison group as of now are not well comparable due to their disproportions. And that would be all. Thank you very much. If anyone has any questions, I will try to answer them. Thank you.
Thank you very much. And now let's move to the discussion.
So the differentiation between the SVT and VT in patients with broad QRS complex tachycardia is a very difficult clinical task, especially based on free channel Holter. So it's this was very hard work. But I'd like to ask you whether what can be the predictors apart from the analysis of the free channel Holter? What clinical data about the patient, the demographics, can indicate that in this patient the VT is more likely than SVT?
I think that when you look at the patient, you kind of may already know that he's having troubles with his heart. The clinical symptoms are going to be more prominent, since I think at least that it would be more more damaging to the heart. So I think that would be the response, but honestly, I have no idea.
Thank you. What I meant is that if we have a patient with structural heart disease, so lower left ventricular ejection fraction, diagnosis of heart failure, history of myocardial infarction or valvular heart disease, if we have a patient with broad QRS complex tachycardia, it's definitely more likely that this patient will have actually VT. But it's just a comment. Don't take it personally. Just
it's okay.
Important data about the clinical history of patient in conjunction with the analysis of the Holter ECG.
Thank you for your input.
I have one question. As I understand, the diagnosis differences between VT and SVT was based on the ICD, yes?
I'm sorry, could you repeat that?
The diagnosis, VT or SVT, was based on the ICD, signals from ICD.
Yes. The patients we analyzed were actually implanted ICD
the population consisted of patients with low ejection fraction, yes?
Yes, they were all implanted with all the patients.
Primary prevention of sudden cardiac death. Okay, thank you.
So that was actually my question as well, but maybe you can tell something about your personal involvement and contribution to this work.
Okay, so we analyzed all of the ECGs ourselves. Our tutor only checked randomly if it was correctly, but he was rather pleased with our work, so there was no need for him to analyze all of them. And then we we calculated the data, and then we created this kind of score, and we divided work equally between all of us. So after that, we just prepared the presentation.
Okay, thank you.
Thank you very much. Thank you for your work.
Now I would like to invite Patrycja Pabis to present the work entitled Baseline Creatinine Level and Long-Term Outcome in Patients with Heart Failure Undergoing COT. The floor is yours.
Your microphone is on.
I try use it.
Chodurek obejrzał?
No, hello, the microphone. Your microphone is still switched on.
Yeah. Jaka była idea, bo to jest PCI z 2021, w czerwcu było, a kontrola była...
Wait 2 minutes, we'll fix it, okay?
Przepraszam, panie Michale, czy możemy prosić o wyłączenie pana profesora?
Thank you. Good morning, ladies and gentlemen, dear audience, dear jury. My name is Patrycja Pabis, and I represent Student Scientific Society and the Department of Cardiology, Congenital Heart Diseases and Electrotherapy of Medical University of Silesia in Katowice. Today, I would like to answer for the question: does baseline creatinine level affects patient with heart failure undergoing cardiac resynchronization therapy? At the beginning, I will tell you why we focus on patients with heart failure. The prevalence of heart failure is increasing, but mainly due to the aging of the population, what you can see on the presented graph. Mortality among hospitalized patients with heart failure is among 20% in patients less than 75 years of age, and more than 40% in patients more than 75 years of age. Implantable devices increase life expectancy. Patients with heart failure who receive CRT device, the mortality rate was less than 10%. CRT improves cardiac function, symptoms, well-being, and reduces mortality and morbidity in those patients. In addition, renal dysfunction has been shown as a mortality predictor in patients with heart failure. However, data on long-term outcomes in patients with CRT and chronic kidney disease is scarred due to the underrepresented group of those patients. The aim of our study was to determine outcome and mortality predictors in patients with heart failure and elevated creatinine level treated with cardiac resynchronization therapy. The study population consists 1,059 consecutive patients with CRT implantable between 2002 and 2019 in a tertiary care university hospital in a densely inhabited urban region of Poland. The men accounted for about 79%. The median creatinine level before CRT implantation was 96 micromole per liter. We divided our patient into quartiles depending on the creatinine level. And in the first quartile, the creatinine level was less than 79 micromole per liter. In the second quartile, 79 to less than 96. In the third, 96 to less than 118. And in the fourth, 118 micromole per liter or more. Table 1 shows Bayley characteristic of whole population and died and lived patients. Died patients were more often older male with higher degree of New York Heart Association, with ischemic etiology of heart failure, with history of diabetes mellitus, atrial fibrillation with lower left ventricular ejection fraction, higher creatinine level at baseline, and severe mitral regurgitation. Patients were treated according to current recommendation. The median follow-up was 1,661 days. The mortality rates increased with increasing number of quartile. In the first quartile, mortality rates was about 37%. In the second, 45%. In the third, 60%. And in the fourth, 72%. The Kaplan-Meier curves shows the survival of patient treated with cardiac resynchronization therapy dependent on the creatinine level. How you see, patient with the highest creatinine level had the smallest survival rate, and patient with the smallest creatinine level, the highest survival rate. The creatinine level equal or more than 118 micromole per liter appear to be an independent risk factor for death. We're looking into baseline characteristic patient with quartile 4. We compared diet patient and the live patient. Diet patient with quartile 4 had a higher degree on New York Heart Association, had lower left ventricular ejection fraction, more often severe mitral regurgitation, and diabetes treated with insulin. The result shows that the lowest ejection fraction before CRT implantation, highest NT-proBNP level 1 day before CRT implantation, and diabetes treated with insulin are the independent risk factors for death in quartile 4. The mortality rate in those with creatinine level equal or more than 118 micromole per liter and left ventricular ejection fraction equal or less than 20% was 88% during the observation. In conclusion, mortality rates in CRT recipients with elevated creatinine level equal or more than 118 micromole per liter is significantly higher compared to those with creatinine in normal range and reaches 70%. More than 85% of CRT recipients with heart failure, creatinine level equal or more than 118, and left ventricular ejection fraction equal or less than 20%, die within 4.5 years since CRT implantation. Thank you for your attention.
Thank you for this presentation, and I invite you to the discussion.
Very big data. Apart from your contribution to gathering this data, I'd like to ask you about why didn't you use eGFR, so estimated glomerular filtration rate, apart from or along with the creatinine level, because we know it's more like more precise indicator of renal function. And the third question is how many measurements of creatinine were performed? Was this a mean of like in hospital creatinine level or just one measurement?
Okay, we used creatinine level because the creatinine level, how you see, is a predictor of mortality. We don't use this parameter like the renal dysfunction, just like renal dysfunction, but how you could saw, the creatinine level was in normal range and the mortality rates was different in normal range. The less creatinine level predict better than the higher creatinine level, and it's very easy parameter. In blood draft, in baseline, we can choose this. So if we saw the higher creatinine level, but it will be okay, 110, for example, we can predict higher mortality rates in those patients. And the second question was, okay, I remember. So it was just one measure at the baseline, first day in the hospitalization.
Mm-hmm. So this is why I asked you this question, because the serum creatinine level can vary depending on the hydration status, and patients who are admitted the first day may be dehydrated because they don't take any fluids or they don't eat prior to admission. So it's wiser to take like a mean of some measurements. And I think eGFR, so glomerular filtration rate, is also an easy parameter. It's given on the results paper. Just it's calculated based on age, gender, and sometimes, of course, when we use Cochrane Gold, we can also include weight. So I would advise in future to use eGFR. It's like a more stable parameter. And my last question is, because you actually meant that it's stratified groups into two mortality risk. I mean, that the patients with higher creatinine level at baseline had higher mortality. But actually, the creatinine level was not an independent predictor in your logistic regression analysis. I did not find it on your in the table here.
Okay.
I don't see it here.
Okay, maybe it's not shown here in the table, yeah. But we calculate then, and the mortality rate was the independent risk predictor for death.
So what was the hazard ratio?
Okay, I don't have here,
okay.
so I don't ask for your question.
I believe you, but this
yeah,
is
okay, I understand. I miss it.
Thank you. Thank you.
Okay, because as I understand from this table, these are independent risk factors for death in patients with the highest creatinine level in quartile 4 already. Yeah. Okay, so did you actually perform the multivariate analysis in the whole population and see if the increased creatinine level is actually an independent predictor of death?
Yeah, we have here that creatinine level.
Yeah, I can see that, but what I'm saying is, did you perform multivariate analysis to see which factors, which parameters were actually independent factors influencing mortality in the old, in the old.
Yeah, we did it,
mortality.
but I didn't show it because it will be in the future publication, and we don't want to show that until the publication. There was more parameters compared. And there were independent risks in whole population, like the age, and there were creatinine level 2.
Okay, thank you.
Actually, it's a paper that comes from my center, but I'm not involved personally in this analysis, so I will ask the question. The determination of the parameters that are that have impact of any prognosis using the multivariable analysis, of course, is always risky. It depends on the model you set up. You found that really the on the previous table, you showed the independent predictors of mortality in the patients with the highest level of creatinine. These are the strong data in your analysis. What would be your explanation? Why do you think that the patients with renal impairment, even if they have CRT implanted, so they are treated in a very efficient way, there is a subgroup of patients with increased risk of mortality? What will be the relation between the renal function and the fatal outcome?
Okay, so the connection between renal function and heart failure is already known, but we just take patients with CRT devices, and I think it's not changed nothing. It's just the correlation between heart failure and chronic kidney disease, and the CRT recipients are just in more more danger, you know, but the correlation is the same. We just look in this this group, maybe is something changed, but it isn't. The correlation is, I told, the same.
Okay, thank you.
Thank you. Any other questions? Okay, so it was the last one. Thank you for your presentation.
Thank you so much.
Thank you very much. And now I would like to welcome Karolina Pax with her presentation, Does the type and location of ischemic stroke affect HRV and apnea parameters in ECG Holter recordings?
Good morning, ladies and gentlemen. My name is Monika Pelcher. I'm fourth year medical student and I represent Medical University of Silesia. Today, I will try to answer the question, does the type and location of ischemic stroke affect HRV and apnea parameters in ECG Holter recordings? Clinical and experimental studies show that there are areas of the brain with the greater influence on a circulatory system through central control of sympathetic and parasympathetic functions. Particular attention is paid to the insular cortex, vascularized by the middle cerebral artery, but cerebral cortex, hypothalamus, brainstem, and spinal cord are also contributed. I would like to pinpoint that MCA is the most common artery involved in a stroke. In our study, we focused on selected types of acute ischemic events: TACI, POCI, PACI, LACI, and of course also TIA and RIND. Autonomic dysfunction is frequently observed after acute ischemic events. Analysis of heart rate variability is a non-invasive method to estimate autonomic nervous system mechanism engaged in heart rhythm control. I would like to emphasize that a decrease in HRV parameters is associated with a higher risk of sudden cardiac death. I would also like to draw your attention that obstructive sleep apnea may also be related to disturbances in ANS activity. This is why we draw attention on apnea-hypopnea index, which is a parameter used to indicate the severity of sleep apnea. It is represented by the number of apnea and hypopnea events per hour of sleep. Up to 5 of these events can be in 1 hour. The aim of our study is the analysis of heart rate variability and obstructive sleep apnea parameters in patients with different types and location of acute ischemic strokes. Out of 339 patients, only 39 patients were excluded due to death during examination, numerous supra- and ventricular arrhythmias, numerous artifacts during recordings. 300 patients were finally included. The study population was divided into 3 groups: TACI, RIND-TIA, and non-TACI. And in this group is more types of previously mentioned types of strokes. So this is why of the reason why this group is the most abundant. Clinical data and Holter results were collected retrospectively from a 3-year period. 3-channel 1-day Holter ECG monitoring was performed in the first week after ischemic event. The following parameters were assessed from Holter recordings: SDNN, RMSSD, PNN 50. and also apnea-hypopnea index was calculated from Holter recordings. As can be seen, total HRV parameters are lower for TACI patients compared to the other groups. Above-mentioned dependence is the most evident for RMSSD total parameter. We also aim to show how the HRV parameters would change depending on the time of the day. Similarly, TECI patient had lower HRV parameters than patient in the other groups. Comparing those groups individually, we achieve following results. For TECI versus non-TECI, the statistical significance was achieved in SDNN-T, so total, and RMSSD day. For TECI, RIND-TIA, it was for SDNN total, and for non-TECI versus RIND-TIA, it was for RMSSD total, RMSSD day, and PNN50 day. Another parameter which was analyzed is AHI. TECI patient had higher AHI than the rest of the groups. RIND-TIA patients had their lowest AHI among the other population. We also checked the percentage of patients in each group that exceed the norm of apnea-hypopnea index, which is estimated as 5. Here as well, the prevalence of TECI group was noticeable. I would like to end with a conclusion. Type and location of acute ischemic event may affect the central part of ANS and may be responsible for changes observed in ARV and AHI parameters. They are most prominent in TECI group. Thank you for your attention, and I will be very happy to answer all your questions.
Are there any questions?
I have one question. Do you have any data concerning on the long-term follow-up in the study population? It's mean, did you find any relation between results and mortality?
Sorry, because I didn't hear the first part of your question. Can you repeat?
Do you have any data concerning on the long-term follow-up in the study population and relation between your result and mortality rate?
No, we didn't do any prospective studies, but we will consider it in the future.
Okay,
thank you for your question.
Thank you.
I'd like to ask you about the purpose of performing Holter ECG in patients following acute ischemic stroke. What is the main purpose? Why do we do this?
As I said, is because those patients with different localization and type of ischemic stroke can have autonomic dysfunction. So we thought that there is a parameter as HRV, which is broadly known that shows autonomic dysfunction, and also apnea-hypopnea index is also related to autonomic dysfunction. So we thought that we are curious if we can see that there is a correlation between allocation of this stroke and autonomic dysfunction.
Yes, your answer was, of course, specific to your scientific task, but I just like to give you maybe a broader context that we can't forget that the main purpose of performing Holter ECG is?
To recognize any arrhythmias or
yes, especially supraventricular ones. Yes, the atrial fibrillation, because that might be the cause of 1/4 of all acute ischemic strokes, and we and based on this we decide whether to introduce a chronic anticoagulation or not in patients with.
Yes, of course.
Yeah, thank you.
Thank you.
To continue this this question, you showed the retrospective analysis of both Holter recordings and obstructive sleep apnea recordings. It means that you collected the data from all 300 patients regarding the obstructive sleep apnea?
Yes, yes.
What was the reason that the patients were monitored?
The reason, actually, because this study, we continue this study. So this dose patient was monitored and 2 years ago. So in 2020, that was the end of this monitoring. And I think it was for research. And of course, to also, as the professor said, to recognize any arrhythmias.
So this was a part of the project?
Yes, this was a part of the project.
Thank you.
Okay, so thank you very much for the discussion and for your work.
Now I would like to invite Dominika Dziadosz to present the work entitled CHA2DS2 score, new fortune teller for NSTMI patients. How about STMI? The floor is yours.
Good morning, dear jury, dear colleagues. My name is Dominika Dziadosz and I represent Medical University of Silesia in Katowice, Poland. And today I have a pleasure of presenting to you a continuation of my previous study titled CHA2DS2 score, new fortune teller for NSTEMI patients. But what about STEMI? Well, hopefully we can find the answer together. As you all know, CHA2DS2 score in the world of internal medicine needs no introduction. It is a highly regarded and widely used tool to assess the risk of ischemic stroke in patients suffering from non-valvular atrial fibrillation. It is comprised of several components such as congestive heart failure, hypertension, diabetes, history of stroke or TIA, vascular disease, age, and sex. But components of CHA2DS2 score are not only risk factors of ischemic stroke, they are also risk factors of other vascular and cardiovascular incidents, such as acute coronary syndromes. And what is even more important is the fact that they are risk factors of premature death. And our previous study has shown that CHA2DS2 score may actually have some clinical usefulness in predicting death in 5-year follow-up after the NSTEMI episode. So the aim of our current study was to determine the effectiveness and usefulness of the clinical application of the CHA2DS2 score in predicting death in 5-year follow-up, but this time among STEMI group. So we decided to perform a retrospective observational study that has taken place at First Turn Clinic of Cardiology of Medical University of Silesia in Katowice, Poland, and patients were hospitalized between 2013 and 2016. We decided to include 150 patients into our database, and half of them were females, and inclusion criteria were as follows: age between 65 to 80 years and STEMI diagnosis. We decided to exclude patients with history of cancer, and then we performed analysis of clinical characteristics and, of course, the 5-year survival. And as you can see, over 51% of patients did not survive the 5-year follow-up period. When it comes to the characteristics of the studied group, we have observed that group of patients that was older suffered from diabetes or ventricular arrhythmias, or suffered from severe chest pain and dyspnea in New York Heart Association class 4 and CCS4, had a lower survival rate. When it comes to the medications taken by our patients after the discharge from the hospital, we have observed that the group of patients that was taking ACE inhibitors and statins had a higher survival rate. When it comes to the group that, in which death was recorded, they presented a higher CHA2DS2 score than the group that has survived. And as you can see on the curve on your right-hand side, you can see that CHA2DS2-VASc score greater than 4 points can predict death with specificity of over 63% and sensitivity of 58%. However, the score that has the highest prognostic significance is CHA2DS2-VASc score of 6 points. But you can also say that this score works in this application because it encompasses well-researched risk factors of premature death like diabetes and hypertension. So we decided to experiment a little and exclude diabetes and hypertension from the score. And as you can see, score modified that way still has statistical significance in predicting death in 5-year follow-up. The situation is the same when we exclude hypertension and diabetes at the same time. However, we're not completely satisfied with specificity, but mostly sensitivity of the score. So we decided to modify it further. And we would like to propose to you a slightly modified version of CHA2DS2-VASc score titled CHA2DS2-VASc plus A, and A stands for an infarction-related arrhythmia, and by that I mean a ventricular arrhythmia that has happened during the acute coronary syndrome or right after it during the hospitalization of the patient. And as you can see, the group in which death was recorded once again presented a significantly higher CHA2DS2-VASc plus A than the group that has survived, and CHA2DS2-VASc plus A can predict death in 5-year follow-up after the STEMI with specificity of over 78%. And what is even more interesting is the addition of low concentration hemoglobin separately in males and females. And the score modified that way can predict death with sensitivity of over 78% in females, and in males with sensitivity of over 85%. So we have concluded that worst prognosis in STEMI patients is of multifactorial origin, and the CHA2DS2-VASc score may be used as a risk factor for death in this population, and even CHA2DS2-VASc with the addition of low concentration of hemoglobin in male population can help predict death in the 5-year follow-up after the STEMI episode. However, I personally believe that the effectiveness of CHA2DS2-VASc score in this application still remains unknown, and we would like to perform a bigger study with a bigger study group to assess that topic. So I would like to thank you for your attention, and of course I invite you all to the discussion. Thank you.
Thank you for this interesting presentation and the graphics, and I can start the discussion.
Thank you. I would like to congratulate you on the work. It was a really impressive presentation. Could you go back to the slide where you actually selected the patients? Because I see you said that you selected 150 patients and 75 of them were women and 75 of them were female. So we have the balance of 50% of each sex. So this was just a play of chance, or did you handpick those 150 patients?
No, it was the decision from the start that the study group should be equal male to female ratio.
Okay, so these 150 patients were actually handpicked based on age and STEMI diagnosis, and what was the other exclusion criteria, right? Because I believe, you know, you have a very equal balance, 50-50%, right? So did you perform any propensity score matching or something like that, or you just handpicked?
No, I just handpicked. We actually handpicked the patients. So we started with males, and then we gathered data about females.
Okay, and you tried to match them as closely as possible, relating to age and other comorbidities?
Yes.
Okay.
Congratulations for the concept of the study to use the CHA2DS2-VASc score in this STEMI patients population. The results you presented show us that this CHA2DS2-VASc score is not a perfect predictor when you look at the sensitivity, specificity, and area under the curve. This is not a very strong diagnostic tool. We would like to use the predictors with much higher sensitivity and specificity and area under the curve, because we use the ROC analysis to measure these tools. Did you have any data from maybe publication, or maybe you thought about this, the comparison between STEMI population and other scores, like a GRACE score? Why did you decide to use HADVASC score?
From what I have found, our study is actually the first study that is surrounded by the relation between the CHA2DS2-VASc and the follow-up. By that I mean death of the patient in such a long period of observation. And I would say that we are very aware of the fact that this is not a perfect score, and we are still working on that. We are still working on increasing the sensitivity, mainly sensitivity of the CHA2DS2-VASc. And why did I choose CHA2DS2-VASc? Well, it all started with the NSTEMI group, because what we believe is that the NSTEMI group is very interesting, because even though it has a lower mortality, lower in-hospital mortality, it has a higher out-of-hospital mortality. And also these patients are older and have many comorbidities. And then we looked at the CHA2DS2-VASc score and thought to ourselves that CHA2DS2-VASc score encapsulates a lot of those comorbidities. So maybe we could find a correlation between them and the 5-year follow-up, and the end point being the death of the patient.
In the last slide, in the conclusion, you showed that the combination of CHA2DS2-VASc and the level of hemoglobin would be the good combination. How did you find that? Because I haven't seen the... Yeah.
When we are researching...
okay, yeah.
Yeah, when we were researching the topic, we also found
and
data
specifically
that...
in males.
Could you repeat?
And specifically in males, the value of this combination has a very, let's say, acceptable diagnostic accuracy, because you increase the specificity, sensitivity, you increase also specificity and area and under the curve. Okay.
I would also like to congratulate you on your results, but CHA2DS2-VASc score is like a risk, a score to calculate the risk of everything in medicine. This is the more data we have, the more information. The greater evidence is that CHA2DS2-VASc can predict death or complications in many group of patients in many diseases, not only cardiovascular, but it's like a method to quantify the risk, taking into considerations all the comorbidities. But in case of this population, maybe it's not the best score, because VA is vascular, so all the patients have 1 point. So maybe it's not perfect, but it's easy because we all know it. So if it's something as a clinical tool, we have many calculators on our smartphones right now, but we don't use them because they're complex. They take time, and CHA2DS2-VASc is something we all know. So that's why we can use it. So it's a very good application.
Thank you.
Thank you for your work. And now we can move to the next presentation.
Thank you very much. And now please welcome Szymon Szostek and the presentation entitled Fragmented QRS and Prediction of Paroxysmal Atrial Fibrillation Episodes.
Okay, good morning, ladies and gentlemen. And it's an honor to address to such a distinguished audience. My name is Szymon Szostek, and I'm a student of Medical University of Silesia in Katowice. Today, I would report on the topic of fragmented QRS and prediction of paroxysmal atrial fibrillation episodes. I would also talk about atrial fibrillation and connected with it the ischemic stroke. And to begin with, I would like to tell that the fragmentation of the QRS complex is defined as an additional spikes within the QRS complex. On the screen, you can see different patterns of the FQRS. And it can be caused by a zigzag conduction around the scarred myocardium. As I mentioned before, it seems that FQRS seems to be related to the presence of abnormalities in the myocardium, and it also may be an indicator or the trigger of paroxysmal atrial fibrillation. Let's now move to Oxfordshire Community Stroke Project. There's a simple system which differs stroke by its location. In our work, in our study, we divided patients into two groups, TACI and non-TACI. TACI stands for total anterior circulation infarct, usually caused by the occlusion of the proximal part of the middle cerebral artery or the internal carotid artery, and non-TACI, which stands for all the other localizations. And there we have PACI. PACI means partial anterior circulation infarct, POCI, which stands for posterior circulation infarct, and LACI, which is for lacunar infarction. We analyze the presence of fragmented QRS in patients with acute ischemic stroke using a 7-day 2-channel Holter electrocardiograph. And 95 patients with embolic stroke of undetermined source has been included in the cohort. They were observed for at least 2 years in our prospective observation. We analyzed and verified the presence of proximal and distal fragmentations of QRS in a 7-day Holter electrocardiograph recordings, separately for the proximal and the distal part of the QRS, and also proximal and distal combined. The endpoint was a recurrent ischemic stroke and or confirmation of atrial fibrillation during the follow-up. As you can see, we didn't have the the correlation between the fragmentation in the channel 1. We have no correlation between the fragmentation and I'm sorry. Between the we didn't have the correlation between the fragmentation of the QRS complex and the localization of the stroke. So as you can see, for TACI and for non-TACI. We also didn't find the correlation in the channel 2. However, we find the correlation for the however, patients with the fragmented QRS complex in the first channel reached the endpoint 3 times less frequent. As you can see, the red line stands for patients who had fragmentation in the QRS complex, and the blue line is for patients without QRS fragmentation. But we didn't find it in the channel 2. Before a conclusion, I would like to put the emphasis on the results again. The incidence of FQRS in TACI and non-TACI was similar. The presence of fragmentation of QRS was more frequent in patients with the endpoint, and patients with no fragmentation had a lower risk of a recurrent stroke or confirmation of atrial fibrillation. And to sum up, fragmentation of the QRS complex may be a risk factor for recurrent ischemic stroke or atrial fibrillation. And on the other hand, the lack of fragmentation of the QRS complex equals lower risk of recurrent stroke or atrial fibrillation. However, the P is really close to the statistical significance, so we need to carry out more studies on this topic. And thank you for your attention, and I'd like to invite you for a discussion.
Does anyone has any questions?
Thank you. Can you tell us why did you choose? Why did you decide to choose the composite endpoint of stroke and atrial fibrillation? Because you analyze it jointly, yes, as a one endpoint.
Yes,
it's kind of like arrhythmia and its complication together. What was the purpose?
Because atrial fibrillation is one of the cause of the stroke, so ischemic stroke. So we connected it, and that's why we choose.
And at the end of your presentation, you said that the fragmentation of the QRS in channel 1 was a predictor of this composite endpoint, but actually the P was above 0.05. So you may say that there was a trend, or it was, however, like it's a very firm statement you used, and I'd say it's only a tendency towards.
Yes, I'm sorry, but I should say that our patients had lower risk. Yeah, and we have to evaluate it.
So thank you for the frank data, because you show that there is some trend. It could be something probably when we will analyze the bigger number of patients. But the concept, I think, is it's okay. It's interesting. I wonder what would be the link between the fragmented QRS that potentially is a measure of structural heart disease. It's a measure actually of fibrosis. So what would be the link between the this QRS indicator and risk of stroke? Could you explain?
Yes, a fragmentation of the QRS is an indicator of the myocardial scar, and in this location, the polarization of the myocardium is slower, and there can be potential point of the re-entry, and from that it can cause atrial fibrillation, and atrial fibrillation can cause forming the clot in the left atrium, and then we can get ischemic stroke in this mechanism.
Thank you for all the questions. Thank you for your work.
Thank you.
Now I would like to invite Aleksandra Budkiewicz to present the work Correlation between 6-minute walk distance and selected clinical parameters in patients with hypertrophic cardiomyopathy. Good luck.
Good morning. My name is Aleksandra Budkiewicz. I attend Jagiellonian University Medical College. Today I would like to present a study, correlation between 6-minute walk distance and selected clinical parameters in patients with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the most common genetic heart disorder defined as left ventricle hypertrophy that cannot be explained by secondary causes. Most patients are asymptomatic, however, due to increased stiffness, reduced size of the left ventricle, and decreased cardiac output. Many others as a major symptom report poor exercise tolerance that impairs the quality of life. Hypertrophic cardiomyopathy leads to heart failure, but also in mechanism in ventricular arrhythmias. It can cause sudden cardiac death. Different tools are used to evaluate functional capacity. The most common is Neurot-Heart Association classification. However, it's a rather subjective method, and patients may vary in their recollections and report over or underestimations of their true everyday functioning. Objective measurements are usually better than self-reports, and because of its well tolerance, wide availability, and cheap price, one of the most popular is 6-minute walking test. The distance covered in 6 minutes may provide a credible information about patients' daily functioning. Several studies have reported that 6-minute walking distance is a reliable measure of increased mortality among cardiac patients, with the distance of less than 300 meters being a strong indicator of poor prognosis. In our study, we aimed to assess how some other factors determine the result of 6-minute walking test in patients with hypertrophic cardiomyopathy. With a Spearman correlation test, we evaluated the relationships of following clinically relevant variables: age, body mass index, Neurot-Heart Association class, heart rate, NT-proBNP plasma level, ejection fraction, left atrium dimension, maximal wall thickness, and maximal left ventricle outflow tract gradient, with the distance of 6-minute walking test, of course. We enrolled 90 hypertrophic cardiomyopathy patients with slight advantage of men. The mean age was about 52 years old, and mean Neurot-Heart Association class 1.63. They all underwent 6-minute walking test. The data were collected retrospectively based on medical records. The mean result of 6-minute walking test was about 418 meters, and almost 20% of patients covered a distance less than 300 meters. When it comes to correlations, moderate negative correlations were shown between 6-minute walking distance and age, as well as Neurot-Heart Association class. It means that the older the patient is, and with the higher Neurot-Heart Association class, the worse the distance is. There were no correlation with BMI. The correlation with NT-proBNP plasma level was found to be weak and negative, and there were no correlation with heart rate. When it comes to echocardiographic parameters, there were no correlation observed in terms of ejection fraction, left atrium dimensions, maximal wall thickness, and maximal left ventricle outflow tract gradient. And this last parameter is very important in hypertrophic cardiomyopathy because the high gradient means obstruction of this outflow tract from the left ventricle, and in some cases it can cause heart failure symptoms. However, in our study, it seems that it does not affect the result of 6-minute walking test. To conclude, the assessment of exercise tolerance by means of 6-minute walking test provides more objective insights rather than subjective Neurot-Heart Association classification to evaluate functional capacity in patients with hypertrophic cardiomyopathy. Surprisingly, common echocardiographic parameters were found not to be related with 6-minute walking distance. And however, age and to a lesser degree NT-proBNP plasma levels seem to be associated with exercise tolerant in hypertrophic cardiomyopathy. Thank you very much for your attention.
Thank you for your work, and now I'd like to invite you to ask the questions.
Thank you for your presentation. I'd like to inquire about the role of 6-minute walking tests in population of patients who actually do not have that much impaired exercise capacity. Do you know, because actually heart failure, symptomatic heart failure is not that frequent in this population, is because of the character. And what can, in patients who have preserved ejection, because the majority of patients with HCM at initial or middle stages of the disease have even greater ejection fraction than the population. Do you know what can be the cause of heart failure or impaired exercise capacity in patients with HCM? What functional abnormality in this subset of patients can lead to this kind of, or probably to impaired 6-minute walking test?
Yes, we found, I think, we thought that maybe it's obstruction of this left ventricle outflow tract can be this parameter that determined the lower result of 6-minute walking test, but in this study it seems that it did not had an effect.
Okay, thank you. Thank you very much. Yeah, that's a very good answer. That's what I thought.
Congratulations for this work. I'm not surprised that the functional echo parameters did not correlate with 6-minute test because we know that, for example, ejection fraction do not correlate at all with oxygen consumption. So there's a general finding in heart failure patients. Specifically in hypertrophic cardiomyopathy patients with normal ejection function, majority of them, I would expect any correlation with some diastolic parameters. So did you look at any diastolic parameters to correlate with functional parameters?
Actually, no, we just took these parameters that I showed here. But maybe it's a good idea to do it in our further studies.
And in terms of methodology, you showed us that you measure the maximal gradient. Does it mean that this gradient was measured at rest or during the exercise, after the walk?
It was after.
When did you measure the maximal gradient? At which time point? At baseline or during the, or just after or during the test? During the walk, actually, because the patient were walking.
No, it was in the rest.
This was the rest measure, okay.
Yes.
Thank you for all the questions.
Thank you very much.
Thank you so much.
Thank you very much. Okay, and now I would like to invite, last but not least, Maria Stets with the presentation HCM-AF Risk Score, Clinical Application in the Prediction of 2- and 5-year Clinical Outcome of Polish Patients.
Thank you. Honorable jury, at last it is my pleasure to tell you something about HCM-AF Risk Score. Its clinical application in the prediction of 2- and 5-year clinical outcome of Polish patients with hypertrophic cardiomyopathy. As you've already heard, hypertrophic cardiomyopathy is a genetic disease causing myocardial hypertrophy. The result of both structural, electrical, and hemodynamic remodeling in HCM may be atrial fibrillation. AF in HCM is associated with 8 times greater risk of thromboembolic complications. Thus, I believe that oral anticoagulants, regardless of CHA2DS2-VASc score, should be implemented in these patients, as well as active search for arrhythmia is crucial in the group. For a long time, there was no tool which could allow actual assessment of the risk of atrial fibrillation in HCM population. But in 2021, the American leaders in the field suggested a novel approach to the problem. The team of Professor Maron proposed a model validated for HCM Boston population, which could assess the risk for AF. It included 4 basic parameters: diameter of left atrium, diameter of left atrium, presence of heart failure symptoms, age at HCM diagnosis, as well as age at the clinical evaluation. The calculator itself stratified risk as low, intermediate, and high. The aim of our study was to assess clinical application of the HCM AF risk score in the prediction of 2- and 5-year clinical outcome in Polish patients with hypertrophic cardiomyopathy. Our retrospective cohort study included 54 consecutive patients with baseline HCM diagnosis and with no atrial fibrillation. Hospitalized, of course, in the first chair and clinic of cardiology from January 2013 up to December 2016. The time of hospitalization was crucial to assess not only 2 but also 5-year follow-up in our cohort. At baseline, we analyzed both clinical and echocardiographic parameters of our patients, whereas as the 2- and 5-year follow-up, we've assessed the endpoints including atrial fibrillation, ICD implantation, heart failure, rehospitalization, and total mortality. The first main and unexpected finding of the baseline score analysis showed that vast majority of enrolled patients was stratified as actually high risk for AF in the risk calculator, with the score exceeding 22. The low risk and intermediate risk had only 2 and 3 patients, respectively. The echocardiographic parameters of the cohort were quite typical for the HCM population. The ejection fraction was borderline, the thickness of intraventricular septum was increased, the average left ventricular mass was increased as well, and accompanied by dilatation of the left atrium, especially in the high-risk subgroup. What's more, the tricuspid regurgitation was accompanied by increased RVSP value. The main endpoint of our study, atrial fibrillation, of course, was especially abundant in the high-risk subgroup. As you can see in the 2-year follow-up, the AF incidence reached 50%, whereas in the 5-year follow-up, the AF occurrence was over 65%. The HCM AF risk score in the high-risk subpopulation was extremely high. It was even higher than in the original cohort of Professor Maron. And what's key here is to see that actually those highest scores were the most abundant ones. As you can see, in the original study of Professor Maron, the score up to 33 allowed assessment of the risk for atrial fibrillation, as you can see in the yellow up here. And the risk for patients with the score between 30 up to 33 was estimated as about 25% in the 2-year follow-up and about 50% in 5-year follow-up. Our study suggests that the AF incidence in the 2-year follow-up varied between 12% up to 100% in patients with the highest scores, whereas in 5-year follow-up it was even higher. The HCM AF risk score is designed to predict if atrial fibrillation will occur, but we could not help but wonder whether it could assess when it will occur. Unfortunately, as you can see on the chart, there's no correlation between the risk score and the number of years free from atrial fibrillation. Verification of other endpoints in our study suggested that both rehospitalization, heart failure progression, ICD implantation, and mortality were more abundant in the high-risk subgroup, especially mortality, which in 5-year follow-up reached almost 47%. In patients who developed atrial fibrillation in our study, all of the endpoints were more abundant, including over 90% hospitalization rate in these patients in 5-year follow-up and over 60% mortality. We are aware that our study is, of course, only one center analysis with limited number of patients. What's more, we might have missed silent atrial fibrillation due to lack of long-term, whole-term monitoring or telemonitoring in AF recognition. Even though I believe we can conclude that Polish HCM population is characterized by relatively high risk score coexisting with high occurrence of atrial fibrillation. Thus, screening for AF should be obligatory in this group. Thank you for your attention.
Thank you for the presentation, and now let's start the discussion.
Okay, thank you. Congratulations for great work. I would like to ask you about how do you think, because there was one surprising finding of your study that the highest risk group, the highest risk, in the group with the highest risk of AF, according to the score you used, the thickness of the interventricular septum was the lowest, which is quite surprising finding, that these patients did not distinguish themselves with the most prominent hypertrophy of the left ventricle, but still had the greatest risk. So I'd like to ask you about your possible explanation of this phenomenon.
Right. I will just move back to the section with the echocardiographic data. Right. Well, I believe in this study, as I've already mentioned, the low risk and intermediate risk groups was actually groups in which we had only 2 and 3 patients. And in the high risk group, we had 49 of them. This is why I believe only the results for the high risk group are significant ones. And the results from the lower and intermediate risk groups are actually biased by the number of patients there.
Very good. Yes, because that might be the bias. Yeah.
Yes, absolutely.
And my comment is on that's the prevalence of atrial fibrillation in the very wide population of patients with hypertrophic cardiomyopathy is 30%, according to the European Observation and Research Program. To the results of the biggest registry so far. So 1/3 of patients have AF. So screening is mandatory, and if we detect AF, we need to act and introduce anticoagulation. Thank you.
Thank you.
Not only the thickness is a surprising finding, but the other morphological measure, when you look at the size of the left atrium,
right.
Actually, the area is bigger in the intermediate risk, where the mortality you showed was 0.
Yes.
So actually, the right atrium seems to be the active seems to play an important role. But I think that not only the morphological measure are the predictor of the occurrence of atrial fibrillation in this group of patients. The other factors, but anyway, the way how we follow patients with hypertrophic cardiomyopathy is important. Echocardiography is a major diagnostic tool, so each patient with confirmed hypertrophic cardiomyopathy has an echo follow-up. So we, of course, measure all these parameters. These parameters are important, and we can, of course, learn from these baseline characteristics. That's true that 30% almost will develop, 30 to 40% will develop atrial fibrillation, but the problem is that once the patient will develop, the efficacy or efficiency actually of atrial of the ablation in this patient is very low, because the remodeling of atria in this group of patients is much more extensive than in other groups. So early recognition and prediction, I think, is very important.
Why do you think you had such a high percentage of patients in the high-risk group in your population?
Actually, I believe this might be a problem of HCM recognition in Poland, because I believe the diagnosis is quite postponed. Since we've compared our study group to the group from Boston, we've observed that both age of our patients was 10 years. Our patients were 10 years older, and the age of diagnosis was much higher.
Okay. And maybe the patients were sent to the tertiary center later, right? And
yes.
Then the the patients with less symptoms were actually treated in the regional centers. So that might be the issue. But the work was very good, and I think in the future, because all these parameters that you collected are relatively easy to obtain, you might expand your population to the different centers and increase the number of patients, and maybe we will see a little bit different distribution of the patients among risk groups.
I definitely hope so, Professor.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you.
It was the last work of our session, so thank you so much for all the papers that were submitted, that you presented. We congratulate all the authors and participants of our session of your work. I hope that it will contribute to increase of our knowledge and scientific value. And now I'd like to kindly ask the president of our jury, Professor Tomasz Kukulski, to say a few words to sum up this session. Professor, the floor is yours.
Thank you. It's a privilege to shortly comment this session, and I think I will express also the impressions and thoughts from my co-chairs. First of all, I would like to congratulate all participants that were presenting the data today. I must say that scientific level is very high. I think it's a reason to be proud that your input to the scientific work, scientific data elaboration at Silesian Center at Medical University of Silesia is important. But not only this medical university, but the data presented from other centers. So once again, congratulations for all the teams. I must say that it's my personal impression that the English every year becomes better and better. So again, this is your personal input to present the data, not only here, because this is actually the area that you can practice, but in the future you'll be also able, I'm sure, to present the data on international congresses and meetings. So the way you communicate with international group is very important. And I think that what we should improve during probably the future our meetings, it's your personal input and personal involvement in the work. As we heard, this personal involvement is very variable. It depends on the center, it depends on you comes from, it depends on the tutor. But generally, the data you presented comes from the retrospective data Of course, we do not expect that you will be involved personally in any randomized prospective trials, because it's difficult to lead such a study. So you are involved in majority in retrospective analysis. But I think that the concept of the way you analyze the data is important, and the concept usually comes from the tutor. So the good tutor is usually the guarantee that the work will be well elaborated, well presented, and the conclusion will be understandable for everyone. So look for the good tutors in order to accomplish and to complete high scientific level data. And I encourage you to also be active in this retrospective data analysis, because when you look at data that are available at different centers, the data are there. So, of course, you should have an impact to this data. And in order to achieve the success, you should use this data and present them with your tutor's help in a most, let's say, efficient way. So thank you very much.
Thank you, Professor, for all these words. Now, let me express the words of thanks to the members of esteemed jury. We truly appreciate your valuable comments, accurate observations, and work on presentation assessment. Dear participants, we would like to cordially invite you to the decoration and closing ceremony of SIMC 2022, which will be held here tomorrow at 4:30. Please remember about our giveaway contest on Instagram. Check it. And now I would like to ask you to stay here after we end this session to take a photo.
Yes, so officially, ladies and gentlemen, the first cardiology session comes to the end. On behalf of Student Scientific Society, I would like to thank you all for the participation in this session. And before I wish you a nice day, I just ask you to come here to take a photo. Thank you so much.
dear participants, ladies and gentlemen, on the behalf of Student Scientific Society of the Medical University of Silesia in Katowice, I would love to thank you all for coming and taking part in the International Medical Congress of Silesia. My name is Maria Stec, and it is my utmost pleasure to coordinate the Invasive Cardiology session.
My name is Olaf Pachtiński, and I also have a great honor of moderating this session. And at the beginning, I would like to cordially welcome the esteemed jury of our session, the president of the jury, Professor Wojciech Wojakowski,
and the members of the jury, Assistant Professor Wojciech Wańcha, Professor Andrzej Ochała, who is with us online, Professor Michał Tendera, who will join us soon, and Dr. Tomasz Bochenek.
Before I present you the rules that we are obliged to abide, I would like to draw your attention to the scientific patronage granted by Club 30 of Polish Society of Cardiology. And at the beginning, I'd like to ask to take the floor Professor Wojciech Wańcha and to tell us a few words about Club 30.
Dear students, dear young scientists, it's a pleasure to be with you today as I maintain today in the morning session. Me as the member of the board of the Club 30 of the Polish Cardiac Society, I would like to provide you some information about the Club 30. Club 30 is the part of the Polish Cardiac Society. It's a unique young community in the cardiology world. It has been founded in 1994 on the initiative of Professor Leszek Ceremurzyński as an integration forum for young Polish cardiologists. The main purpose of the club as a platform is to establish networking among young doctors training in the cardiology field. The members of the Club 30 shape the face of the Polish cardiac cardiology, becoming involved in the various clinical, scientific, social, and political activities. Dear students, the main project of the Club 30 right now are specialized research fellowship, which support young scientists in the implementation of research programs in the foreign expert centers. The second program is the Club 30 scientific platform, which is the place for initiating multi-center research and writing application for the research grants. There are some strict rules to be the member of the Club 30 of the Polish Cardiac Society. Firstly, you have to be the member of the Polish Cardiac Society. Your age should be less than 35 years, and I think the most important point is the impact factor should be at least 5, obtained by the publication of 1 or 2 original articles as the first author. Thank you for your attention and hope to see you in the club in the future.
Professor, thank you for your words. And dear participants, before we start the first prelection, let me explain you the principles and rules of our session. The order of the presentation will be the same as in the abstract book published before the conference. The maximum time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time of the prelection, he or she needs to move on to the conclusion and finish the presentation as soon as possible. Don't be afraid, I will let you gently know that the time is over. Please remember that the presentation and the discussion must be run in English. And
the jury will assess 4 aspects of each presentation: scientific value, way of presenting, discussion, and own contribution to the work. Esteemed jury, when the session ends, we kindly ask you to give the cards back to the coordinator.
I think
everything
is clear, or maybe there are some questions, organizational questions. Okay, so we can
open the session and start the first presentation. So I would like to invite Jerzy Bartuś with the presentation on large vessel coronary artery perforation treated by covered stents. The floor is yours.
Thank you. Dear jury, dear colleagues, I will talk about large vessel coronary artery perforation and the treatment with covered stents of this disease. So I will this is a short summary of a publication from PLOS ONE which we make with 4 other centers. That is a very big registry, and Professor Wańcha made the publication from data that 5 places we were making together. I'm one of the co-authors. Usually, the covered stent implantation is the first-line treatment, followed by cardiac surgery. If the bleeding persists, the use of covered stent is an effective strategy for treating coronary artery perforation with favorable event-free survival. The covered stent consists of metallic stent platform covered with a synthetic or biological membrane that seals the blood extravasation. Data about clinical outcomes of coronary artery perforation treated by coronary stent implantation are scarce. Although the devices have been used for many years, only a small number of studies describe peri-procedural and long-term outcomes. In the current report, we present procedural in hospital and 1-year results of patients treated with covered stent implantation for iatrogenic peri-PCI coronary artery perforation. The primary endpoint was the composite of major adverse cardiac events defined as cardiac death, cardiac lesion revascularization, and myocardial infarction assessed after 1 month and 1 year from the index procedure. Secondary endpoints were stent thrombosis and the individual invets on the primary composite endpoint. Target lesion revascularization was defined as any revascularization procedure within the treated lesion. Stent thrombosis was defined as acute till 1 day post-stent implantation, subacute from 1 day till 1 month, or late from 1 month till 1 year. Successful perforation sink was defined as no contrast leak and no cardiac surgery intervention needed after covered stent implantation. This registry included data of patients with coronary artery perforation treated by covered stent implantation. All stents were implanted into a vessel of minimum 2 mm diameter and were delivered to the perforated segment, and the rest of treatment was in accordance with the recommendations of the clinical practice guidelines. We defined lesions according to the most popular classifications, and we used other most popular tests to just to calculate the statistics. So the population was 119 patients. The mean age was 69 years. 55.5% patients were men. Acute coronary syndromes was the presenting diagnosis in 73 cases, and chronic coronary syndrome in 46. 36% patients had a history of myocardial infarction, 37% had a previous PCI, and 12 had a prior coronary artery bypass grafting. 46 patients developed cardiac tamponade either during or post-procedure. The pericardiocentesis was performed in 45 patients. Cardiogenic shock was observed in 30 patients. Notably, emergency cardiac surgery was performed in 14 patients. 6 patients during the procedure required the use of mechanical circulatory support. Periprocedural death was observed in 8 patients. Those patients were excluded from the 1-year analysis. Successful seeing of coronary artery perforation with covered stent implantation was achieved in 99 patients, and 12 patients had to go to cardiosurgery to be healed. That's the graph of it. And cumulative 30-day MACEs were observed in 15 patients. Of those, 6 patients experienced cardiac death, 8 target lesion revascularization, and 6 myocardial infarctions. Furthermore, 4 patients had acute stent thrombosis, and 1 patient had subacute stent thrombosis. During 12-month follow-up, the cumulative MACEs were observed in 26 patients. Of those, 7 patients experienced cardiac death, 13 target lesion revascularization, 11 myocardial infarctions. 1 patient had late-stage thrombosis. So there is a curve, Kaplan-Meier curve of these states. And we see that over 17% of, no, it's like 70% of patients didn't get any of these endpoints. And in the first 30-day follow-up, only one target lesion revascularization was observed in patients who underwent emergency cardiac surgery. During 1 year follow-up, the cumulative MACEs were observed in 2 patients. Of those, 1 patient experienced target lesion revascularization and 1 had myocardial infarction. To our knowledge, the current report is one of the largest analyses presenting in hospital and 1 year clinical outcomes following coronary artery perforation during PCI treated by covered stent implantation. Implantation of covered stent is a successful treatment of coronary artery perforations. This real-world data on coronary artery perforations treated with covered stents illustrated that the procedural and 1 year outcomes of coronary artery perforations triggered by covered stent implantation were a delayed follow-up of the patients as they are at increased risk of MACE. Events of stent thrombosis warrant further studies and use of intravascular imaging to optimize the covered stent implantation may be indicated. So thank you. And I will be honored to hear questions.
Thank you for the presentation, and the discussion is open. So if you have any. Okay.
So could you explain me what kind of stents did you use, the covered stents? And another question is whether the perforation was post-balloon or post-stent implantation? How many in percent? Do you have any tables on that?
I could it from the presentation, but mainly it was in the predilatation, as I remember, and we used Graftmaster, Papyrus, covered stents. About them would be next presentation, and then the stents that we cut from the next presentation were bare metal stents, which don't have the membrane.
Are there any other questions? Okay, thank you so much for your presentation, for questions.
Thank you. And I believe you did not need to move much because there's your other presentation coming. So large vessel coronary artery perforation treated with covered stents implantation, comparison between poly tetra. The floor is yours again.
Okay, thank you. So from the population of a previous study, we made another study where we were comparing Graftmaster and Papyrus stents. And the publication is now in Journal of Clinical Medicine. And we were doing it from Jagiellonian University. So coming back to how often it is this coronary artery perforation, it's in 0.17 till 0.43% of patients during percutaneous coronary interventions. And the construction of covered stent consists of a metallic stent platform covered with a synthetic expanded polytetrafluorourethane Graftmaster or electrospun polyurethane Papyrus or biological membrane pericardium that seals the blood extravasation. The differences in the type of stent cover and structure, sandwich or out in layer cover, impact the endothelialization process that prolongs stent thrombogenity potency, similar to other implantable devices. This biocompatibility translates into a significantly higher risk of adverse events with covered stents as compared to drug-eluting stents, but not to bare metal stents BMS. In previous studies, there were no broad reports on the effect of variance within covered stent structure type. To address this evidence gap, we conducted a study focusing on 1 year results and predictors of clinical outcomes of coronary artery perforation patients treated with Graftmaster and Papyrus implantation. So 2 types of covered stent were evaluated, GraftMaster and Papyrus. The main technological differences between the 2 stents are graft material and stent design. The GraftMaster covered stent is constructed using the sandwich technique, whereby a layer of expanded polytetrafluorourethane is placed between 2 stainless steel stents. A PK Papyrus covered stent is a single layer 90 micrometers electrospoon polyurethane covered cobalt chromium stent. The primary endpoint was the composite of major adverse cardiac events, defined as cardiac death, target lesion revascularization, and myocardial infarction, assessed at 1 month and 1 year from the index procedure. The secondary endpoints were stent thrombosis and the individual events of the primary composite endpoint. Target lesion revascularization was defined as any revascularization within the treated lesion. Stent thrombosis was defined as acute, till 1 day post-stent implantation, subacute, like in previous one. Outcome data were obtained from the central database of National Health Fund Service of the Ministry of Health. We used similar technological devices to count statistics, and same classifications we also used. The registry included 106 patients with coronary artery perforation, among which 51 received GraftMaster and 55 Papyrus covered stents. There were no significant difference in age, gender, or concomitant disease between the GraftMaster and Papyrus group. 50 patients died up to a year. 18 were followed up to a year, but we had follow-up till 350 days, so it's like a year. And 53 patients were at the risk. No statistically significant differences were found between the GraftMaster and Papyrus groups in the occurrence of REP-SCI, cardiac death, myocardial infarction, or MACE during the 30-day follow-up. Papyrus covered stent implantation resulted in a significantly lower incidence of target vessel revascularization and target lesion revascularization when compared to GraftMaster. There is a table where we can see all the numbers. And after 1 year follow-up, there were no statistically significant differences between GraftMaster and Papyrus covered stent in the prevalence of MACE or REP-SCI, with a trend towards lower rates of target lesion revascularization, target vessel revascularization, myocardial infarction, and stent thrombosis in Papyrus group. A trend towards a lower rate of cardiac death was observed in the group managed by GraftMaster stent implantation. And we observed a trend towards a lower overall stent thrombosis rate in Papyrus group compared to GraftMaster group during the 1 year follow-up period. And we will show it on the Kaplan-Meier curves, where we can see this. And the covered stents did not differ in implantation technique, but in their technical design, from which the difference is the prevalence of clinical events may have found. And the GraftMaster predisposes to increase non-intimal hyperplasia and subsequent delayed endothelialization at the proximal and distal edges, resulting in a magnified risk of instant restenosis. In conclusion, this real life registry of coronary artery perforation illustrated that the use of Papyrus-covered stent is associated with lower rates of target lesion revascularization and target vessel revascularization at 1 month follow-up in comparison to GraftMaster covered stents, and no significant differences between both assessed covered stents at 1 year of follow-up. So that's all. Thank you.
So the discussion is open. Does any member of the jury have any questions to the participant?
Did you look at what kind of antiplatelet drugs were used after implantation? Did you make any difference as to target vessel? problems?
I think that they are normal. I think that there are no many different.
But did you check it, or you just didn't concentrate?
No, I didn't check this.
Okay.
But I can check later.
And what was your role in this study?
In this and previous one, so I checked the data from our university, from our hospital of university with covered stents. Then I was calling the patients. It was sometimes very hard to collect the data from patients during those phones, and that was my contribution to the first publication. And for the second one, I did what I did in the first one, but also I was looking for more publications to make the discussion and to make the work. And also I was making the work with some other people who helped me from the clinic.
Okay, because of the delay, we need to skip one work by Grzegorz Procyk. It will be at the end of our session. And now I would like to invite Zofia Kampka, to present the work Clinical Characteristics and Predictors of In-Hospital Mortality Among Patients Undergoing Pericardiocentesis. The floor is yours.
Okay, how can I change the slides in here? Ladies and gentlemen, my name is Zofia Kampka, and I would like to invite you to our presentation, Clinical Characteristics and Risk Factors of In-Hospital Mortality Among Patients Undergoing Percutaneous Pericardiocentesis. Here is the plan of my presentation. Firstly, I would like to focus on percutaneous pericardiocentesis itself. It belongs to life-saving procedures in cardiac tamponade, while it may also serve as a diagnostic procedure in patients with symptomatic and recurrent pericardial effusion refractory to medical treatment. The clinical characteristics and prognosis may differ depending on its etiology, and I will be returning to this point later. Let's now move on to the aim of our study. We wanted to evaluate the clinical characteristics of patients subject to percutaneous pericardiocentesis and to assess the in-hospital mortality risk factors among these patients. As far as patients and methods are concerned, our retrospective study embraced 208 patients and 231 procedures. All of them were performed in Upper Silesian Medical Center in Katowice in years 2011-2021. The inclusion criteria involved all patients who were submitted to this procedure, regardless of the etiology of pericardial effusion. Exclusion criteria involved data incompleteness regarding the etiology and the outcome. Our primary endpoint was in-hospital mortality, while secondary endpoints were cardiogenic shock, requirement for packed red blood cells transfusion, and referral to intensive care unit. As for general characteristics, our study embraced 109 women. The median age was 66. The median BMI was 27.52. I would like to stress that cardiac tamponade was around 90% of pericardial effusion cases. What's more, around 10% of patients required second intervention. The median hospital length of stay was 8 days during the first percutaneous pericardiocentesis. We could also observe the ECG abnormalities in around 23% of patients. Having discussed the general characteristics, let's now move on to the further results of our research. The most common indications for percutaneous pericardiocentesis were neoplastic disease, followed by idiopathic effusion, coronary artery perforation due to percutaneous coronary intervention, viral pericarditis, cardiac electronic device implantation, catheter ablation, and post-pericardiotomy syndrome. I would like to draw your attention to the fact that iatrogenic cause was the most common indication for this procedure. The median volume of drained fluid was 550 milliliters. The overall number of deaths was 11, and among them one was a procedure-related death. Complications occurred in 11 patients. Moreover, 26 patients suffered from cardiogenic shock. The same amount of patients required packed red blood cells transfusion, and 25 patients had to be referred to intensive care unit. Now let's have a look at the complications of this procedure among those 11 patients. The most common were sudden cardiac arrest and heart perforation. Univariate analysis indicated that the in-hospital mortality was prognosed by PCI-related etiology, history of pulmonary embolism, cardiogenic shock, sudden cardiac arrest, baseline pericardial drainage volume, right bundle branch block, and last but not least, requirement for packed red blood cells transfusion. Logistic regression analysis indicated that PCI-related etiology, history of pulmonary embolism, and cardiogenic shock were independently associated with higher in-hospital mortality. In conclusion, I would like to say that iatrogenic etiology was the most common indication for percutaneous pericardiocentesis, and what's more, PCI-related coronary artery perforation confers the greatest risk of in-hospital mortality. Now I will be delighted to answer your questions. Thank you.
Thank you for the presentation, and I will the floor.
Thank you. So one question and one comment. The question is, how did you define the cardiogenic shock? Because the cardiogenic shock is a part of tamponade presentation. So was it a cardiogenic shock after initial stabilization, or cardiogenic shock that may have been there already when the pericardiocentesis was done?
It was the cardiogenic shock related to the cardiac tamponade.
Okay, okay. And the comment is, when you prepare the publication, the acute case in terms of volume of drainage, it's different than the neoplastic disease, for example, because for slow accumulation, there could be 1 liter inside and the patient will be relatively stable. And for acute decompensation, it could be 150 cc that will produce the cardiogenic shock. So you should split the presentation into iatrogenic and chronic disease that require the drainage. Okay.
Thank you for the comment.
Are there any other questions? Okay, thank you so much.
Thank you. Moving on to the next presentation, I would like to invite Natalia Gołąbek with the presentation entitled Clinical Characteristics of Patients with ECG Patterns Suggestive of High-Risk Coronary Anatomy in NST-ASC. The floor is yours.
Thank you. Dear jury members, ladies and gentlemen, my name is Natalia Gołąbek, and I'd like to invite you for my presentation where I'll be discussing clinical characteristics of patients with ECG patterns suggestive of high-risk coronary anatomy in non-ST segment elevation acute coronary syndromes. As we know, acute coronary syndromes are divided into ACS with and without persistent elevation of ST segment, which is crucial for the patient's management. In the case of ST ACS, the standard treatment is reperfusion carried out as soon as possible, up to 2 hours. However, when NST patients are considered, they are subject to the so-called risk stratification, which determines the urgency of performing coronary angiography and possibly coronary revascularization. In the beginning, I'd like to recall the last 2020 update of EST guidelines for the management of NST-ACS, where it was noted that in such patients, certain electrocardiographic recordings may indicate, including significant culprit stenosis or occlusion of left main coronary artery and proximal or middle segment of LAD, despite the lack of Parde wave in the ECG. These patterns, which may indicate a need to remarkably accelerate the invasive strategy, called in our research high-risk ECG recordings, include the winter sign, which is, as we know, a 1 to 3 millimeter upsloping ST segment depression turning into tall, positive symmetrical T waves in precordial leads, Wellens syndrome, a two-phase or deep negative symmetrical T wave in leads V2 and V3, and finally, ST segment depressions by at least 1 millimeter in at least 6 classical ECG leads with simultaneous ST segment elevation in AVR and or V1. And considering the point of clinical view, the aim of our study was to assess the patient's characteristic representative for mentioned recordings and additionally analyze possible factors that may increase the chance of this phenomenon occurring. We have evaluated medical charts of 187 patients previously hospitalized in the 2nd Department of Cardiology at the University Hospital in Krakow with the final diagnosis of NST-ACS. After applying the exclusion criteria, which included incomplete medical records and lesions limited to RCA, 93 patients with admission ECG and performed coronary angiography entered the final analysis. Then we divided the patients into two subgroups based on the presence of significant culprit stenosis or occlusion of LMCA or proximal middle segment of LAD. And after analyzing ECG recordings, 17 patients representative of a high-risk ECG group were identified. It was 7 men and 10 women with the mean age of 71 and the standard deviation of 10 years, and their 41 counterparts. Out of 93 patients, 58 suffered from the critical stenosis or occlusion of mentioned arteries, and high-risk ECG findings were present in 17, 9, 2, and 6, respectively, cases, which was 29%. Presented table additionally describes the occurrence of lesions, in particular localizations, divided by exact ECG pattern. We'll also like to present observed findings of proximal LAD lesions in the patient with Wellens syndrome, middle segment LAD lesions in the winter sign subject, and finally, ostial LAD lesions in ST segment depressions case. The most important part of our study was to assess the clinical characteristics of those patients, and there were no significant intergroup differences concerning the collected data, which included hypertension, diabetes, nicotinism, renal failure. We've also assessed if it was the first CAD presentation and the previous medical history. And then we also divided the patients into groups based on gender. And as we can see in this table, which summarizes the biochemical records, there were no significant differences except for higher serum potassium in high-risk ECG women, not men. And the p-value for Fisher LSD test was 0.027. And P for interaction by ANOVA was also significant. And the conclusion that we can take is that since those mentioned patterns are suggestive of high-risk coronary anatomy and are relatively frequent, we should think of them as indicators to remarkably accelerate the invasive strategy. Our unexpected finding of higher serum potassium in women on admission, but not men, is fairly preliminary, so we are not going to formulate any far-going conclusions. But at the moment, we are planning to expand our study for a larger group of patients, probably with cooperation with other departments. And with that in mind, I would like to end my presentation and answer if any questions. Thank you.
Thank you for the presentation. Does any member of the jury have a question?
I would like to congratulate the study. I've got one question. Did you exclude patient with pacemaker?
There was one patient, and he was excluded. Yeah.
All right. Thank you.
Mm-hmm.
Do you plan for long-term follow-up, like mortality?
Yes, for sure. Mm-hmm. Because now the group was not so large. We think that to get significant results, we have to plan a larger study. Mm-hmm.
There was also a group with non-critical LAD, which was excluded.
Yes.
Did you look at some patterns there?
No, because we analyzed the subgroups that had changes larger than 40%.
But it could be interesting maybe
yeah.
to see if there are also patterns, and maybe look retrospectively at their ejection fraction, or maybe look closer at the mechanism of what happened, why it was such an ECG pattern in lower risk patient, in a good coronary.
Thank you for this comment. Yeah, for sure.
Thank you.
Mm-hmm. Okay, thank you.
Okay. Thank you for this interesting presentation. And now I'd like to invite Mikołaj Guzikowski to present. Sorry, okay. So Kamil Turczynowski, you are invited to present the work entitled Efficacy and Safety of the Angiosyl and Proglide Vascular Closure Device in Patients Submitted to Coronary Angiography. The floor is yours.
Thank you very much. Good afternoon, ladies and gentlemen. My name is Kamil Turczynowski, and it is my pleasure to present to you the results of our study on the efficacy and safety of the Angiosyl and Proglide vascular closure device in patients submitted to coronary angiography. Firstly, I would like to tell you what the devices actually are. They are designed to allow for rapid closure of femoral arteries in patients subject to coronary angiography and percutaneous coronary intervention. Basically, their main goal is to obviate the need for prolonged compression and facilitate early ambulation. Next, I would like to mention a few common side effects according to the manufacturers. They contain bleeding or hematoma, AV fistula or pseudoaneurysm, and device failure, malfunction, or even misplacement, among others. The aim of our study was to evaluate the rate of arteriolar puncture site vascular complications using the Angiosyl and Proglide vascular closure systems on femoral arteries, in contrast to the traditional pressure dressing in patients undergoing coronary angiography. Let's take a look at our materials and methods. Ours was a retrospective case control study. It was based in one center, and we evaluated 60 patients that were admitted to the hospital in 2020. Our inclusion criterion was for the patient to have undergone coronary angiography via femoral or radial approach. Our composite endpoint was consisted of onset of hematoma, pseudoaneurysm, prolonged bleeding, arterial venous fistula, arterial dissection, or acute limb ischemia. Now let's take a closer look at our results. As I said, we evaluated 60 patients, 25 of whom comprised the study group, which were treated via the femoral approach only. Proglide was used in 1 patient, and Angiosyl was used in 24 patients. And the control group consisted of 35 patients, among whom 26 were treated via femoral approach and 9 via radial approach. The median age was 72.5 years, and 60% of the patients were men. Here I would like to mention, to compare a little bit the study group and the control group. As you can see, they were pretty similar, but arterial hypertension was more prevalent in the control group, and atrial fibrillation occurred more commonly in the study group. Here, the most interesting thing to me is that the majority of coronary angiography procedures ended in a PCI. That's what you can see on the bottom of the table, because it was over 70% of cases in both groups. Now let's see how many complications there were. We had a relative risk of 0.71 with 95% confidence interval, 0.2 through 2.59, and the p-value equal to 0.61. And in the study group, 16% of patients experienced some sort of vascular complications. That means 4 out of 25 patients. And in the control group, it was 11%. That means 4 out of 35 patients. Now let's see what the actual complications were. In the study group, there were 2 cases of prolonged bleeding and 1 case of arterial dissection and pseudoaneurysm each. And in the control group, there were 2 cases of femoral hematoma and 1 case of arterial dissection and pseudoaneurysm each. That makes 8 patients with complications out of 60 patients total. That means 13.3%. Now I'd like to compare the group that experienced some complications to the group that experienced no complications. As you can see, all the patients that experienced complications were treated via the femoral approach, and half of them experienced atrial fibrillation. And actually, that's pretty interesting to me that percutaneous coronary intervention was done in all of the patients that exhibited some complications. To conclude, we were able to observe that the use of the devices does not reduce the rate of vascular complications in patients treated via the femoral approach, but there are some other upsides like faster ambulation and overall improvement in the quality of life of patients submitted to coronary angiography. Also, we were able to see that the radial approach would be the preferred option because in our study we saw no complications at all in those patients. And moreover, vascular closure devices were more frequently utilized in patients with the need for additional anticoagulation because of AF and in whom dual antiplatelet therapy was necessary because of PCI. And as I already said, patients with vascular complications more frequently underwent coronary angiography via femoral approach, as no complications were reported in patients treated via the radial approach, and they had higher prevalence of AF and higher rate of PCI. That is all from me. Thank you very much, and now I will answer any questions that you might have.
Thank you. Are there any questions?
Can you comment on the control group, because the control group is mixed?
Yes,
it's radial actually, and femoral. Yes.
Yes, that's right.
Why? Because if you want to compare the complications related to the vascular closure device in the femoral artery, why didn't you compare to the femoral artery without vascular closure device? Because per definition, the radial artery complications are different than the femoral, and is different. The risk of complications is different for radial artery.
Yes, actually, you are right that the devices are only used. They are not used when the patient is treated via the radial artery approach, but we kind of decided that it would be interesting to see if there were any complications in patients treated via the radial approach.
Okay, so probably the conclusion should be that just descriptive statistics on how often you see the complications related to the vascular closure device.
Yes, I think you're right. Thank you.
Professors, any other questions? Okay, thank you very much.
Thank you for this presentation, and now we can invite Mikołaj Kuleszyński, Michał Kawa, and Wojciech Hojna with the presentation on implantable cardioverter defibrillator patients, antiarrhythmic interventions. In one side, 10 years of follow-up. The floor is yours.
Thank you. Ladies and gentlemen, it is my great pleasure to be able to share this work with you today. Sudden cardiac arrest is a leading cause of death in the world. It generally occurs in the setting of impaired cardiac function and structural heart disease that lead to ventricular tachycardia or ventricular fibrillation. Current approaches to the management of ventricular tachycardia involve the use of antiarrhythmic drugs, cardioverter defibrillator implantation, or catheter ablation. Antiarrhythmic drugs are the least invasive, but they can have significant side effects, and for some patients, they are not effective enough. ICDs have better efficiency, but it's a quite invasive procedure, and the eventual shocks are very unpleasant. Also, it also prevents death, but does not treat the underlying cause of arrhythmias. Catheter ablation may be the only option for some patients, but the procedure is quite lengthy, and it involves destroying tissues. Therefore, this is the most invasive. Thankfully, there is a new method that can potentially solve many of these problems. Stereotactic radiotherapy is a technique for treating targets anywhere in the body and has been widely adopted in the management of a range of cancers. Initial study has demonstrated the potential to use non-invasive stereotactic cardiac radiotherapy, for short STAR, to treat ventricular arrhythmias that cannot be managed with current invasive methods. Our retrospective study is part of a currently ongoing SMART-VT trial in our center. It is the first Polish attempt to treat ventricular tachycardias using this innovative method. Data is based on nearly 1,500 patients of Upper Silesian Medical Center who got ICD implanted from 2010 to 2021. In this study, we evaluated how many of them can potentially benefit from STAR treatment. First of all, we would like to present a general overview of the population. As you can see, there is a massive disproportion of sexes of implanted patients. Almost 80% of the population is male. The mean implanting age is 64 years, regardless of sex. Patients treated with ICDs often suffer from cardiovascular problems. 77.5% of them have been diagnosed with ischemic heart disease, while 60% has experienced ventricular myocardial infarction before implantation. Ischemic heart disease was significantly more prevalent among men than women, 80% versus 68%. The same was with MI, 62% in men and 55% in women. According to heart failure guidelines by the European Society of Cardiology, implantation of ICD in primary prevention is advised when left ventricular ejection fraction is below 35%. Such patients constituted 71% of this group. 29% of the population had previously experienced ventricular tachycardia or ventricular fibrillation, which led to implantation of ICD in secondary prevention. Close to 19% of patients implanted due to primary prevention has received adequate in-device treatment, including anti-tachycardia pacing or electric shock, that potentially saved their life. This situation is called a conversion. The conversion was not dependent on the ischemic heart disease present, but it was far more prevalent in the male population. In the male population, one in 5 patients eventually developed life-threatening arrhythmia that was successfully stopped by the device, at least once or more. Compared to 13% of women, it is more than 1.5 times more prevalent in male population. The potential beneficiary of STAR treatment is the patient who has experienced ventricular tachycardia in his lifetime. This means almost 1/3 of our population who got ICD implanted in secondary prevention, plus almost 1/5 who experienced ventricular tachycardia after implantation. Together, these two groups make up almost half of the total population. In our population of 1,424 patients, 600 of them are probable candidates for this innovative treatment. STAR treatment has the potential to permanently reduce the chance of developing ventricular arrhythmias, as well as being less invasive and less complicated procedure than current invasive methods. It was a lot of data and a lot of numbers to process in such a short time. That's why we want to underline the most important findings of this study. The first conclusion is that male gender, ischemic heart disease, and previous MI seems to predict the need to consider various advanced antiarrhythmic therapies, such as ICD. What's more, we established that nearly as much as 50% of the population with implanted ICDs is potentially eligible for STAR treatment. There are over 200,000 patients who got ICD implanted every year. According to our study, almost half of them might develop ventricular tachycardia in their lifetime. That's why we think it is of the utmost importance to get to know this population better. Thank you all very much.
Do you have any questions from the jury to the presenter?
So I think for the conclusions, it's difficult to say if the male gender and ischemic heart disease predict, because it should be based on the prediction model related to regression analysis. So it's from this study, it's significant difference in the rate of male, female versus the rate of acute history of an MI in patients between the groups, but it's not a predictor based on this study. Predictor is something very specific, okay? And the general comment is that the activation of the ICD, it's not a failure of the device, it's a success of the device. Yes. And the STAR technique is very early in the clinical study. It has to be tested in the study. So it's now only restricted to patients with refractory arrhythmic events despite ablation. So those two populations are not exactly the same. So probably only 5% of the patients eventually may have benefits from the STAR. So it's a little bit far-reaching statement. So probably, potentially, the group of patients that may have the STAR ablation is much smaller, okay?
Okay, thank you.
Thank you for the question. Do we have any others? Thank you.
Thank you, dear participant. And now I would like to invite Oliver Piechota to present the work Incidence of Atrial Heart Rate Episodes in CRTD Recipients, a single-center retrospective observation. The floor is yours.
Okay, good day everyone. My name is Oliver Piechota. I'm a fifth-year student of the Medical University of Silesia. And I wanted to present you today our presentation about the incidence of atrial high rate episodes in CRTD recipients. It's a single-center retrospective observation. So now to the background. CRTD is an implantable cardiac resynchronization therapy defibrillator for patients with heart failure. The device monitors the heart rhythm, detects irregularities, and corrects them with electrical impulses. We included patients with heart failure with a reduced ejection fraction who had the risk of atrial arrhythmias. Patients with atrial high rate episodes are at a high risk of major adverse cardiovascular events And these arterial high rate episodes are defined by Medtronic with over 175 beats per minute, and by Biotronic by over 200 beats per minute, lasting at least 5 minutes. The aim of our study was to evaluate the occurrence of ARIA in CRTD recipients, the clinical evaluation and the impact of ARIA on the death and survival analysis. Our material and methods were 52 patients who underwent CRTD implantation as a primary prevention at the first chair and clinic of cardiology of Medical University of Silesia in Katowice between the 1st January 2012 and the 31st December 2018. And the follow-up time ranged from 135 to 4,286 days, which is about 12 years, and included at least 5 visits at the clinical dispensary. So our inclusion criteria were first into 1 and 2A class recommendation on CRTD implementation as of the ESC 2016 guidelines. Left bundle branch block or non-left bundle branch block QRS morphology. QRS lasting at least 130 milliseconds and the age over 18 years, as well as a left ventricular ejection fraction under 35%. The exclusion criteria were lack of follow-up, so patients who had less than 5 visits were excluded, as well as ACS, KBG, and PCR in the last 3 months. The administration of inotropes and vasopressors, and patients after heart transplant. Here you have a summary of the report after follow-up. As you can see, the atrial pacing was under 1% and the biventricular pacing was over 99%, and there were no episodes of ARIA as well as no ventricular tachycardia and ventricular fibrillation episodes. And in general, our group, there was an average age of 64 years and a weight about 86 years. Significant, there is that 90% of the group were actually male and were in the NIHR class 2 or 3. The average length of QRS was 157 milliseconds and left ventricular ejection fraction about 27. And most of the patients actually took beta blockers, loop diuretics, mineralocorticoid receptor antagonists, as well as ACE inhibitors. And in this group of 52 patients, 56% had ARIA in the follow-up and 44 didn't. Here in the group characteristics, you can see that there is no significant difference between these two groups. But in the hemoglobin, there was statistically significant difference. The patients with ARIA had a hemoglobin of about 14, and the patients without about 13. As well as in the use of angiotensin receptor blockers. In the patients without, there were about 22%, and in the patients with, only 3%. During our follow-up, 19 patients died, and as you can see, the occurrence of ARIA had no impact of the survival. So to our conclusion, during our 5.5 years observation, the occurrence of ARIA in CRTD recipients was 56%. And the study did not show a meaningful difference between patients with ARIA events and patients without ARIA, without them, which lead us to the effect that ARIA incidents did not affect the patient's survival. And thank you for your attention, and I would want to invite you for discussion.
Interesting study.
First question, did you exclude patient with atrial fibrillation?
Yes, we also exclude.
And atrial flutter also?
Yeah.
And in how many patients did you find atrial fibrillation when you had AHRE? In ECG, in Holter. Did you test it or not?
No, in a follow-up.
Because in AHRE we can read from the device, and to recognize the atrial fibrillation we have to perform the ECG.
Yeah, in a few patients they had, but we didn't include it.
Because it is interesting, how many patients do we have atrial fibrillation and atrial fibrillation or atrial flutter in patient who has who have AHRE in the device? Because it is this is the crucial point. To find the patient who has atrial fibrillation or atrial flutter with AHRE, to recognize atrial fibrillation. But congratulations, very good study.
Thanks.
Why is there difference in diagnosis of AHRE from those two different devices, 175 and 200? Do you know? There was another definition for AHRE.
Yeah, it's
for biotronic. What's the reason? Do you know?
Actually, I don't know. It's probably the producers have different references, right? Yeah.
Okay.
Thank you for the questions, and thank you for your presentation.
Thank you for your presentation. I've just received the information that we were joined by Professor Tindera. So welcome, Professor. It's an honor for us to have you here with us. And now we can start with the presentation, Long-Term Outcomes of DEB versus DES in Chronic Coronary Syndrome Patients with In-Stent Restenosis by Marta Hamera. Please, the floor is yours.
So good afternoon, ladies and gentlemen. My name is Marta Hamera, and today I would like to present you our research about long-term outcomes of drug-eluting balloon versus drug-eluting stent in chronic coronary syndrome patients with in-stent restenosis. Nowadays, percutaneous coronary intervention with drug-eluting stents is more and more frequently performed and a well-established treatment option for patients with obstructive coronary artery disease. Despite the constant progress in this branch of invasive cardiology, the Achilles heel of PCI with stent implantation poses a risk of different complications, including in-stent restenosis, which occurs in 4 of patients at 2-year follow-up, and its treatment remains challenging. Moreover, in-stent restenosis represented about 10% of all PCI procedures, and the proportion of ICR procedures is slightly increasing over time in spite of the development of new generation stents. According to current European Society of Cardiology guidelines, the use of drug-eluting balloon and drug-eluting stent are recommended for patients with DES in-stent restenosis and simultaneously have the same level of evidence. Therefore, in this study, we aim at comparing long-term outcomes in chronic coronary syndrome patients who were treated with either drug-eluting stent or drug-eluting balloon because of DES in-stent restenosis. This registry is one-center observational study conducted. Data included 119 consecutive chronic coronary syndrome patients with DES in-stent restenosis who met inclusion criteria and did not meet exclusion ones, and were also treated with either paclitaxel drug-eluting balloon or thin drug-eluting stent. Patients were divided into 2 groups. 59 of them were treated with drug-eluting stents, and other 60 patients received drug-eluting balloon. Patients who received both types of PCI during the same procedure or had only balloon angioplasty or PCI of other vascular territories at the same procedure were excluded. Also, patients with instant stenosis in a bypass graft, or those who had repeated intervention at target lesion, including those with multiply stent layers, were excluded. Median follow-up in this registry was 3 years, and primary endpoint, which was used to assess efficacy and safety of both devices, was target lesion revascularization. The secondary endpoints were target vessel revascularization, myocardial infarction, cardiac death, and device-oriented composite endpoint, which was defined as composite of target lesion revascularization, target vessel myocardial infarction, and cardiac death. So by looking at baseline characteristic, we can observe that patients who received drug-eluting stent had more hypertension, hyperlipidemia, and family history of coronary artery disease. On the other hand, patients with drug-eluting balloons were more often current smokers, had more peripheral artery disease, and larger ejection fraction. Other patient features including age, diabetes mellitus, chronic kidney disease, atrial fibrillation, and previous cardiac interventions failed to demonstrate significant differences in both groups. Based on angiographic and procedural data, patients with single vessel disease more often received drug-eluting stent than drug-eluting balloon. The most common vessels receiving both DEB and DEs during PCI procedures were left anterior descending artery and right coronary artery. Additionally, there were no significant differences between groups according to types of instant stenosis. However, there were some relevant differences according to device data, and we can see that implanted drug-eluting stents were longer in comparison to drug-eluting balloon. As far as intracoronary imaging is considered, we can notice that results are similar in both groups. During follow-up, the study's primary endpoint, target lesion revascularization, occurred in 4 of patients who received drug-eluting balloon and 2 patients treated with drug-eluting stent. The incidence of secondary endpoints, including target vessel revascularization, all-cause myocardial infarction, target vessel myocardial infarction, death, and DOCE, did not differ significantly in both groups. And on this slide, there are Kaplan-Meier curves for target lesion revascularization according to the use of device. And here we can see no significant differences between drug-eluting stent and drug-eluting balloon groups. And there is also a presentation of Kaplan-Meier curves for secondary endpoints. And similarly to the previous chart, there are no significant differences in both groups. So to sum up, this registry of data referring to using drug-eluting balloon or thin drug-eluting stent in chronic coronary syndrome patients with DES instant stenosis revealed similar outcomes of both devices regarding target lesion revascularization. Furthermore, there were no significant differences in secondary endpoints, which consist of target vessel revascularization, myocardial infarction, cardiac death, and device-oriented composite endpoint and long-term follow-up. So that's all. Thank you for your attention, and if you have any question, I would like to answer.
Hello, this is Michael Dunbar. First of all, I would like to apologize for being late, but I did explain the delay to the organizers. Again, it's a pleasure to be with you. So let me just congratulate you on setting up such a nice group for a single center. However, definitely the primary event is very, very rare, and you really cannot draw any conclusions from such low numbers like 2 versus 4. And if I were you, I would have predicted this, and I would have opted for some kind of a composite endpoint rather than this single endpoint, because formally you cannot draw any conclusions from the secondary endpoint in case the primary endpoint is negative. So in the future, I would suggest to you to think better about the primary endpoint. Otherwise, I have no reservations. It's a nice presentation. Thank you.
Okay, thank you.
I have two questions. Why did you exclude grafts, and what's the reason that DEP is better than DES in your opinion?
Okay, so maybe I will start the second question. When we use DEP, we don't enter foreign body to the vessel, and for example, in the instant restenosis, we have previous descent. So when we probably enter the second layer of metal, it's a higher risk of some other complication, including instant restenosis or stent thrombosis. And first question about grafts. So we excluded them because we only focus on lesions in coronary arteries. So yeah, we excluded it.
Thank you.
Did you look into it? Because I think this is a very important and interesting problem. Just of curiosity, I would suggest you to look into the question of how this behaves in grafts rather than in the native vessels. But that's for the future, of course.
Okay, can you repeat the question because I didn't heard?
I'm sorry, that was just a comment. I think that the problem of the comparison of DES and DEP within the grafted vessel or within the grafts is interesting. And my suggestion was that in the future you would perhaps, like when the group increases, also look into this problem.
Okay, thank you for this comment.
Thank you for the comment, Professor.
Thank you. Thank you for your presentation. Dear participants, according to the order, the next work should be the work by Wiktor Skotarczyk concerning the body mass index, but because of the absence of the participants, this work is this is cancelled. And now I'd like to invite our foreign participants. You are welcome, Normundus Vilmundsons, to present the work entitled The Impact of PACE and ablate treatment surgery on quality of life in patients with permanent atrial fibrillation and congestive heart failure. You are online, so we are listening. The floor is yours.
Sorry, Normund, are you
So, I'm sorry, can you hear me now?
Yes, we can hear you.
Okay, thank you very much for the introduction. My name is Normund Vilmundsons. I'm a sixth-year medical student at the University of Latvia in Riga, Latvia. And today I would like to present our research titled The Impact of PACE and Ablate Treatment Strategy on Quality of Life in Patients with Permanent Atrial Fibrillation and Chronic Heart Failure. So despite, atrial fibrillation and chronic heart failure are both frequently coexisting morbidities with increasing prevalence and incidence around the Western world. And they can both serve as a cause and a cause for exacerbation of each other. And despite optimal medical treatment, both of these conditions are associated with frequent hospitalizations and diminished quality of life. So the PACE and ablate treatment strategy, which involves cardiac pacemaker implantation and a subsequent AV node ablation, has been shown to improve the quality of life and lead to fewer hospitalizations in these patients. So in our study, we aim to evaluate the impact of PACE and ablate treatment strategy on quality of life and the number of one-year hospitalizations due to AFib and/or chronic heart failure in patients with permanent AFib and chronic heart failure. So the study consisted of two parts: a retrospective longitudinal study in which we analyzed the patient's medical records, and a cross-sectional study in which a quality of life questionnaire was administered to the consented patients. And the study was done in the Latvian Center of Cardiology. And now moving on to the results. In the study population consisted of 41 patients, of whom 29 were male and 12 were female. And the mean age of participants was 67 years old, ranging from 46 to 87 years old. Now, regarding the quality of life, the patients were asked to assess their quality of life on a scale from 1 to 10. And as we can see, the median quality of life before PACE and ablate was 2 points, and after the PACE ablate, the median quality of life was 8 points, again on a scale from 1 to 10. No patients reported that their quality of life has diminished due to this treatment, and most of the patients reported that their quality of life has improved by 3 to 6 points. Regarding the continuing the evaluation of the quality of life, 37 patients, as you can see in this table, or 90.2%, deemed that the treatment has had a positive effect on their quality of life, and the same number of patients reported that they would undergo this treatment again, and they would like that this treatment to be offered in an earlier stage of their disease. 21 patients, or 51.2%, did not report that they retained any previous symptoms after this procedure. And I would also like to point out that for 4 patients, their cardiovascular disease was a cause for them to change or leave their current profession. Regarding the clinical symptoms before and after the PACE ablate, the most commonly reported symptoms before PACE ablate were palpitations, shortness of breath, excessive tiredness, dizziness, or other, which mainly consisted of pedal edema. And after the PACE ablate, the most commonly reported symptoms were excessive tiredness, with 3 patients reporting continuing shortness of breath or dizziness. Regarding the number of one-year hospitalizations, as I mentioned before, we only counted the hospitalizations which were due to AFib and/or chronic heart failure. So the mean number of one-year hospitalizations before PACE and ablate was 4.4 hospitalizations, ranging from 1 to 9 hospitalizations. And the mean number of hospitalizations after the PACE ablate was 0.24. I would also like to point out that 32 patients had no reason for a hospitalization caused by AFib and or chronic heart failure, and no patients reported additional or increased the number of hospitalizations that they had. And regarding the actual changes of hospitalizations, you can see that it ranged from reducing to -1, hospitalization to even -9. But for most patients, it was -2, -4, and -5 hospitalizations. And so we concluded that the PACE and ablate treatment strategy improves the patient's quality of life and reduces the actual number of hospitalizations in patients with permanent atrial fibrillation and chronic heart failure. And thank you very much for your kind attention. I will be happy to answer any questions that you may have.
Thank you, dear participant, for your presentation. And are there any questions?
Thank you very much and congratulations. Was there any formal statistical test used to compare between the observation, the longitudinal analysis? How did you compare?
Yes, all of the reported results were statistically significant.
Okay. And what test did you use? Was it a repeat measures test? Because there was. What test did you use for statistical evaluation?
For statistical analysis, we used the paired between the subgroups. We used paired T-sample tests.
Thank you.
Yeah, this is Michael Tandera. Why didn't you use any of the existing the proof tests measuring quality of life? I understand that you made up your own 10-question questionnaire. Was there any reason to do that rather than using something that it does exist and is well established?
Thank you for your question. The reason for that, because in similar studies, the patients the patient groups were somewhat a bit different. So we deemed that in our study we will create our own quality of life questionnaire due to, like I said before, in similar studies the patient groups were sometimes they were a bit different.
Okay, and my second question is just making sure that when you say hospitalization numbers, you have in mind only hospitalizations due to heart problems or atrial fib?
Yes, we only included the hospitalizations caused or due to atrial fibrillation and or chronic heart failure.
All right. And do you want to continue this and make some kind of a case control study that would compare this group or the group treated this way with the group treated in the standard way? Case control. Yeah. Go ahead.
Yes, we are. This is only a small part of, let's say, bigger study in which we are planning to add a control group of patients which with the medical treatment of both of these conditions, and we are also currently assessing the impact of PACE and ablate on left ventricular ejection fraction, New York Heart Association class, and the impact on medication usage by these patients.
How did you pick up your patients? How did you choose your patients for this kind of treatment?
So the patients for this treatment were treated according to the indications of European Heart Society. So there were two criteria for the PACE and ablate treatment. The first was.
Sorry, we cannot hear you, Normans. Sorry, Michał Nowak, do we have any internet error?
Implanted pacemaker, or in most cases, there were patients with implanted CRT or cardiac resynchronization therapy. But for these patients, due to atrial fibrillation, the actual biventricular percentage of stimulations was low. So according to the guidelines, the actual percentage was below 90%.
Well, thank you very much. I'm very pleased with your response. Thanks a lot.
Thank you very much for your comments.
Thank you for the presentation. Now I believe we can move on to the next one. So the nitrosative stress in rats with heart failure maintained on a normal fat or high fat diet by Karol Sadowski, Karol Momot, and Adrian Bednarek.
It's a great pleasure to be here. My name is Karol Sadowski, and today I would like to show you results of our work about the heart failure and also the high-fat diet or the normal fat diet. So at the beginning, I will highlight here three aspects: the nitrosative stress, so where the amount of the NO is higher, also this type of the heart failure with preserved ejection fraction, and I think the most common one, the high-fat diet. So at the beginning, nitrosative stress. So this is a condition where the the amount of the NO is higher, and we know that because the activity of the inos is higher, so that stimulates the NO. So we observe the inos after a heart attack, but also after the inflammation. So in case of the inflammation, for example, in obesity, this concentration of that enzyme is higher. So what's more, I will highlight that later. And now we are more and more talking about the pathogenesis of that heart failure with preserved ejection fraction. In case of this inos activity, is connected with this unfolded response, unfolded protein response. However, we are not able to explain that still in details. And a few words about the heart failure with preserved ejection fraction. So this one of the two types, with the second one with the reduced. So here this ejection fraction is similar to the normal, of course, to the left ventricle. And it's commonly associated with hypertension, atrial fibrillation, and much more. But in this case, I would like to highlight the obesity. And the last aspect, and the symptoms of that heart failure are non-specific, so the diagnosis is not that easy during our first visit. So there are some symptoms like a chest discomfort, dyspnea, the decreased exercise tolerance, or the fatigue. And in the high-fat diet, I think the most common one, I would like to highlight here that this fat tissue, it's stimulating the cells to release these inflammatory mediators, which causing the general inflammation, the systemic inflammation. And now more and more research are showing that it's triggering this nitrosative stress. So our aim of the study, we performed that on the rats. We would like to determine if this high-fat diet or the heart failure alone could elevate this inos level, and to find some correlation between this type of the heart failure and nitrosative stress. So we performed that on the 66 rats, and we divided them into four groups. So we used two types of the diets, the normal fat diet and also the high-fat diet. And we perform on standard ligation, which leads to the heart failure, or the sham operation, which is the fake one, where we are only triggering the coronary arteries. And here you can see the protocol. So we use 4 weeks old rats, and during the next 12 weeks, we are giving them a high-fat diet or the normal fat diet. But after 8 weeks, we perform the standard ligation or the sham operation, and after additional 4 weeks, we collected their tissues from the left ventricle. And after that, we perform the Western blot, and we measure the concentration of the inos, pro-BNP, and acting as a control marker, the anti-pro-BNP as a marker of the heart failure. And after that, we compare that by the ANOVA. So here you can see our difference, but okay, so some the quality I think is not the best. But in the two groups with the heart failure, we showed that there is a greater concentration of this pro-BNP, so we confirmed this heart failure. And after that, we compared the activity, the amount of the inos, this enzyme. Sorry for the quality. So the inos level was the highest in this group where the high-fat diet and also the with the heart failure. And in the rest of the groups were the results were similar without any statistical changes. And we also compared these two groups, this high-fat diet with the sham operation, and also normal fat diet with the heart failure. And there weren't any significant differences between them. So what we can conclude from that? So our conclusions are a little bit different than in the past research, maybe because we performed that on the rats. So the heart failure or the high-fat diet, which leads to the metabolic syndrome and obesity, is alone, they cannot lead to the nitrosative stress. However, when we combine these two features, that stimulates the nitrosative stress, and that nitrosative stress could lead to this type of the heart failure, heart failure with preserved ejection fraction. However, to confirm that, we would like to check that model because there are some strict criteria to confirm that. So thank you for your attention. I encourage you to ask some questions.
Well, thank you very much for the presentation. This is Michael Tandela. I like it because it represents kind of a translational work, bench to bedside, probably. And I'm wondering, what was your role in the entire project?
Okay.
In the concept, running the experiments, analysis of the results, what was it?
Mm-hmm. Okay, so we hold that with the Adrian and also the Carol, and the Carol performed these surgeries, and after that we were analyzing the data. We performed the Western blot, and we analyzed that with the Adrian.
Okay, well I gather that the entire duration of the diet was 12 weeks. Am I right?
Could you repeat it?
Yeah, what was the total duration that the animals were fed the high-fat diet?
So
12 weeks or 8 weeks?
Okay, so we tried to lead to the metabolic syndrome. So that was our aim, and to obesity. So that was our aim to using that for the 12 weeks.
12 weeks, okay. And what was the percentage difference in body mass of between the two groups?
So the body mass wasn't statistically significant. So we only saw the differences in the mass of the heart. However, that leads to the metabolic syndrome, but we cannot say that was the obesity. So.
Okay. Well, I think that probably you have already corrected this, but in the title you refer to heart failure, and in the conclusions you refer to myocardial infarction. It's a minor thing, but when you publish it, please pay attention to it. And I think that your conclusions regarding heart failure with preserved ejection fraction are far too far-reaching. Yeah, I wouldn't include them in the conclusions. Perhaps this could be discussed, but I don't think, especially taking into account the model that you were using, that is ligation of LAT, I don't think that you can make any conclusions regarding heart failure with preserved ejection fraction.
Yes, of course, I must agree, and in future we'd like to confirm that, because there are some strict criteria in some papers to confirm that, but I know this is a strong assumption. Thank you for comment.
Does any member of the jury have any other question? Thank you for the discussion section then, and thank you for the presentation.
Thank you.
Thank you very much. Now I'd like to ask Wiktoria Smyła to present the work, the relationship between the frequency of PPI after TAVI and the distance between the AV ring and the IVS. The floor is yours.
So, good afternoon, ladies and gentlemen. My name is Wiktoria Smyła, and I am fourth-year med student of Medical University of Silesia. Today, I would like to present you my study about the relationship between frequency of permanent pacemaker implementation after TAVI and the distance between the aortic valve annulus and the intraventricular septum. So TAVI, which is transcatheteral aortic valve implementation, is a relatively new method because it was introduced in 2002. Severe aortic stenosis, which is the most common valve disease in adults, is the most indication for this procedure. Some of you may ask, which patients are suitable for TAVI? So TAVI is dedicated for non-operative patients with high and intermediate risk of surgical treatment, and for patients with above 75 years old with low risk of surgery, in whom TAVI can be performed through the femoral artery. So please look carefully on the left side of the slide, because this figure represents the increasing number of performed TAVI, and thanks to the aging of the population, we believe that the TAVI will be more popular methods. On the right side of the slides, you can see the comparison between mortality, transvascular TAVI and traditional surgical valve replacement. And as you can see, the TAVI has this mortality lower than traditional methods. As any other medical procedure, TAVI has its own complication, and today I will be focused on need for permanent pacemaker implementation. Please look carefully on the vertical axis, which represent the pacemaker implementation rates. And as you can see, this rate that differs in different centers, and this can ratio be below 10% up to 30% in different hospitals. The aim of my work was to assess the frequency of permanent pacemaker implementation and to evaluate the impact of the distance from the annulus of the aortic valve to the muscular part of the intraventricular septum. So my study was based on one single registry from Zabrze TAVI. Our study population conducted of 76 patients. They were implanted with Evolut Air Pro self-expanding valves, and the exclusion criteria was previous permanent pacemaker implementation. As you can see, the mean age in the study population was around 77 years, so this was elderly patients, and males were the majority. In these slides, I would like to show you some scans from computer tomography. You are looking on the plane of the aortic annulus, and the red line represents the distance between the aortic valve annulus to the muscular part of the intraventricular septum. And that was the methods of taking the measurements of this distance. Now let's move to the most important part of our presentations, to the results. So we divided our study population into 3 groups based on the value of the distance of the aortic valve and the intraventricular septum. And as you can see in the group number 1, where this distance was under 3 millimeters, we got 18 patients. In group number 2, where this distance were between 3 and 6 millimeters, we got 25%. And in the group number 3, where this distance was above 6 millimeters, we've got 33 patients, and group number 3 was the largest group. the frequency of the permanent pacemaker implementation after TAVI in our center was estimated on a level of 9.2%. And the main indication for this permanent pacemaker implementation was a third degree FO block. Now, please look carefully on the figure, because this figure represents the permanent pacemaker frequency in each group. So in the group number 1, whereas this distance was under 3 millimeters, we've got only 2 implementation. In number group where this distance between aortic valve annulus and the muscular part of the intraventricular septum was between 3 and 6, we've got 4 permanent pacemaker implementation, and in group number 3, we've got only 1 permanent pacemaker implementation. We also, during the statistic analysis, we would also like to provide some kind of comparison between different groups, but as you can see on this figure, any comparison was statistically significant. Some of you may ask what type of the permanent pacemaker were implemented, and as you can see, we've got only 1/3 of the implementation and 3 implementation of single and 3 implementation of double chamber permanent pacemaker. So going to the final conclusion, I would like to say that the frequency of permanent pacemaker implementation after center was low, because it was estimated on the level 9.2%. And there was no significant association between the frequency of permanent pacemaker implementation after TAVI and the distance between aortic valve annulus and the intraventricular septum. So thank you for your attention, and I invite you to the question.
Michael Tandera, if I may. Well, congratulations on this presentation. I would like to first have 2 minor technical remarks. The first relates to the title of your presentation. I very strongly discourage you from using abbreviations in the title. When you say PPI, the first thing that crosses my mind is proton pump inhibitors. And I think this is very misleading. So don't use the abbreviation. That's the general rule for the titles. The second one is that you were talking about implementations, and probably you had implantation in mind, but this is only minor. I think that it's an interesting question, although both your group is relatively small, and the number of events is also small. So drawing any conclusions from these data is stepping on very thin ice. So I would rather suggest that you enlarge your group and give it some more attention before you publish these results. Thank you.
Okay, thank you for your comments, and I will keep it in mind in the next works.
So I think you have very good results, because a single-digit number of pacemaker after self-expandable valve is very good result. So that's why the final results yielded only small numbers per group. So probably my suggestion would be to look at the patients who had any degree of AV block before, because this is also, or bundled branch block before in the implant, because this is only also a strong predictor of permanent pacemaker after TAVI. And secondly, probably look at the 2 groups comparison between like 5 or more and 5 and less, or 3 or more, 3 and less, and try to find if there is any signal, because for such good results and low number of implants, you won't probably have much significance, but this is a very nice result.
Okay, thank you for your comment.
Thank you for the paper. And now we can go back right to Grzegorz Procyk with the paper number 3 on the card, with the title Characteristics and Outcomes of Patients Consulted by a Multidisciplinary Pulmonary Embolism Response Team. The floor is yours. Good luck.
Thank you. Good afternoon. First of all, I would like to apologize for my delay, and of course it's a great honor and pleasure to present the results of our study, summarizing the characteristics and outcomes of patients consulted by a multidisciplinary pulmonary embolism response team. So let me start with some statistics, as pulmonary embolism is the third most frequent acute cardiovascular condition worldwide, and its prevalence is estimated at about 100 to 200 per 100,000 of inhabitants each year, and therefore it generates annual costs ranging to 8.5 billion euros in the European Union alone. So this major burden of pulmonary embolism to public health implies the need for optimizing the strategies for pulmonary embolism diagnosis and management. And regarding also the complexity of qualifications of patients for interventional treatment, as well as delicate balance between the risk of death due to the disease itself and treatment associated complications. The concept of pulmonary embolism response teams emerged in 2012 in Massachusetts General Hospital. The main goal of this PERTS is, of course, to optimize and accelerate treatment implementation in pulmonary embolism patients, especially at intermediate high and high risk of mortality, by gathering experts from various disciplines of medicine. This is interventional cardiology, as well as emergency medicine or cardiothoracic surgery. Following the European Society of Cardiology recommendation to establish this local pulmonary embolism response teams, the Center for the Management of Pulmonary Embolism was also established in 2017 in Warsaw. It consists of 3 centers. This is European Health Center in Otwock at the Medical University of Warsaw, as well as Medicover Hospital. So this is a multi-center retrospective study. And the algorithm of activation of Silesia consists of 4 stages. The first stage is clinical assessment conducted by a treating physician, and patients at high risk or intermediate high risk of pulmonary embolism are identified, then consulted by the CELSAT through video teleconsultation and phone call. Then there is made up the decision. Decision is made up whether to implement the interventional treatment or just pharmacotherapy. And after the intervention, patients are hospitalized in cardiac intensive care units or just intensive care units to stabilize the general condition. So patients who presented to any of the participating centers diagnosed with pulmonary embolism between September 2017 and December 2021 were included in our study. We obtained data from medical records, and they included data like demographic data, symptoms and signs at presentation, as well as risk factors for venous thromboembolism, comorbidities, relevant laboratory and imaging findings such as cardiac troponins concentration, as well as natriuretic peptide concentration, or computed tomography or echocardiography, as well as venous thrombosis location, and in-hospital pharmacotherapy and outcomes in hospital, and 1 month outcomes. So during this 52-month period, there were 235 CELSAT activations, 104 in Medical University of Warsaw, 116 in European Health Center Otwock, and 15 in Medicover Hospital. The mean age of patients was 60 years. The majority of patients were men. The most common symptom at admission was dyspnea at minimal exertion or at rest. This is NIHA class 3 or 4. What's interesting, the least common symptom was hemoptysis. Malignancy was the most frequent pulmonary embolism risk factor, followed by obesity and recent hospitalization. And noteworthy, nowadays the risk factor for pulmonary embolism was previous COVID-19 infection in 14 cases. So the mortality, the risk of mortality was low in 51 patients, as well as intermediate low in 83 patients, intermediate high in 80 patients, and high in 21 patients. The vast majority of patients presented with thrombus located centrally and bilaterally. The central location of thrombus was defined as in the saddle or pulmonary artery or lobar artery or intracardiac location, while the peripheral location was defined as segmental and subsegmental location. So the anticoagulation alone was the most frequently administered treatment. This trend applied to all subgroups of patients except for the high risk of mortality patients, where the interventional treatment was the most common treatment. And at discharge, the most common applied treatment was direct oral anticoagulants, followed by low molecular weight heparins and vitamin K antagonists. Outcomes. So in hospital, the mortality rate was 6.5%, and we also recorded 12 events of minor bleeding, as well as 7 events of major bleeding. There were 3 cases of stroke and 1 case of recurrent pulmonary embolism. During 1 month follow-up, there was 1 case of death and 1 case of minor bleeding, 1 case of major bleeding, which in turn in a 1 year follow-up resulted in death, and also 1 case of stroke was reported. So to conclude, PERT implementation enabled patient-tailored decision-making, as well as better access to advanced therapies with subsequent low overall mortality and treatment complication rates. However, further research is required, especially regarding the clinical efficacy and also economic efficacy in patients at intermediate low or low mortality rate risk. So I'd like to thank my tutors. This is Associate Professor Aleksandra Gąsecka, as well as Dr. Arkadiusz Pietrasik, as well as my colleagues, without who this work could not be conducted. Thank you very much for your attention.
Thank you, dear participants, and sorry. Congratulations. Are there any questions to the participants?
This is Michael Van der again. I think it's an excellent idea, of course. The amazing thing is that there were, on the average, only 4 patients per month in this system, and it indicates that it has to be popularized, and perhaps the general idea should be to centralize the treatment of high-risk patients. I would strongly recommend that you do popularize this approach. I understand that it's not going to be very easy to join forces with many other centers, but I think it would be of a great advantage to those with high-risk pulmonary embolism. Congratulations.
Thank you.
Congratulations. It was great. I think that we are facing a new era in treatment of pulmonary embolism, because it's like years ago we faced it with primary PCI for infarction. Now we are concentrating on pulmonary arteries more. My question is whether this response team in Warsaw works 24 hours daily, and if invasive cardiologists and surgeons are always disponible to do those procedures, because they are long-lasting and probably they are not using the same stuff as for intervention in infarction.
Okay, thank you very much for these questions. First question, so to answer, yes, this CELSAT works 34 hours per day and 7 days in a week. And to the second question, I don't have this information, so I don't know if these invasive cardiologists are available for all the time. But
go ahead.
I assume that if CELSAT alone works 24 hours and 70 days per week, so invasive cardiologists should also be available as well.
Just out of curiosity, did you have any surgical interventions within the group with interventional therapy?
Yes, I think that there were only a few surgeon interventions, but there were like only a few. The most commonly applied interventional treatment was thrombolytic treatment, and if I remember, 19 patients received also filters. However, I don't remember, but a few cases were of surgeons, made by surgeons, but only a few cases in this population in this whole population.
Okay, thanks.
Thank you.
Okay, thank you very much.
Thank you.
All the submitted papers have been just presented. We congratulate all the authors and participants of our session. We hope that you enjoyed this time and that the exchange of views and observations will contribute to increase of our medical knowledge. Now let me express the words of thanks to the members of our jury, also those members who are here and those online. And at this point, I would like to kindly ask the president of the jury, Professor Wojciech Wojakowski, to sum up this session and share with us a few words.
No, it's a great honor because you are on the first step of your scientific development as students, as young doctors, investigators. So I'm really happy to see so many abstracts presented in such, I would say, mature way, and many, our discussion and our remarks were not really a critique. It was just a way we try to help you improve for the next step of your scientific work. So all the abstracts were really interesting and well done, and the concepts were sound. So I think you will work based on what you already done and produce scientific papers or next abstracts. So I'm really happy to see so many students interested in the field of interventional cardiology, cardiac surgery. So congratulations to all of the speakers, co-authors, and the final verdict is not a beauty contest. It will probably be driven by 1 or 2 point differences between the scores, so don't feel disencouraged if you are not the first one, but really all the abstracts were interesting and nicely presented. Thank you very much.
Thank you for these words, Professor. We are deeply honored and truly appreciate the time you decided to give us, and thank you very much for all the attention, comments, and work on presentation assessment. I believe the session of invasive cardiology has come to the end, so thank you all for the attention and for your time. Now we can consider it closed. Thank you.
Thank you very much. Good work.